Anil, you have to unmute yourself.
We are live.
Start?
Yes.
Okay. Hello, good morning, friends and colleagues. It is my pleasure to welcome you all to our webinar today, a discussion on advanced cardiology. Before I move on to the business, as you all know, the vaccination drive for healthcare workers is gathering momentum, and at the same time, number of COVID cases are steadily decreasing. Therefore, we are looking towards encouraging and brighter side of things. Hopefully, most of us have already had our first dose of COVID vaccine. I would request everyone to alleviate any misconceptions and doubt regarding the vaccine and suggest that you all get your jab as soon as possible. I would like to thank, on behalf of the Bombay Seaboard Medical Association, the BMC, for excellent arrangements at all vaccination centers and also their stellar work during the pandemic. We are thankful to the Government of India for caring for the healthcare workers and excellent handling of the pandemic. Now turning to our main subject on the webinar on advanced cardiology, as well as keeping up with our traditions, we have today interesting lectures by very eminent cardiologists, Dr. Ajit Menon, Dr. Miran Tella, Dr. Hamidullah, Dr. Jumana Yusuf Haji. I would like to thank Dr. Anil Mehta, Dr. Jawahar Mukhtiar for organizing today's webinar. We are fortunate to have Bombay Medical Union, Sir H.N. Reliance Foundation Hospital, GPA, FFAPI, the Bombay A Ward and D Ward Medical Associations, and Jain Doctors Federation for joining us. I now hand over to Dr. Anil Mehta to take over the proceedings.
Good morning and welcome to the webinar, the very famous our webinar, first Sundays of every month. As Dr. Kamlesh just mentioned, if we recall, on 30th January 2020, India recorded the first coronavirus case. A year has passed since. We have lost more than about 1.5 million people in this pandemic. The vaccinations are gradually picking up very well, and our country has now become the fastest in the world to give more than 4 million doses so far. Many of the listeners must have taken the first shot by now, and they have not experienced much side effects. I take this opportunity and this platform to thank and appreciate the BMC and the government authorities for excellent arrangements and very smooth process and almost a 5-star experience. So, which I'm sure all of you will agree. Coming to today's CME on cardiology update, intracoronary imaging provides a very precise assessment of coronary artery disease. And now it is widely accepted as a critical step in identifying the culprit vessel and helping to decide a precise modality to act upon. So that way we have a very able speaker, Dr. Ajit Menon, with us. The second part of the today's talk is mainly focused on the cardiac failure. And as we said that chronic heart failure patients are regularly visiting our OPDs, there is a lot more than mere medical management. Today, we are going to discuss all new things. We have three very, very able speakers. They will take us through the journey, dealing this very complex but common problem to us and trying to take it to the logical end, like bridging a bridge to the transplant. So may I call upon BMU President Dr. Vibhavkar Advaryu to introduce our first speaker, Dr. Ajit Menon.
Thank you, Dr. Anil. I have the proud privilege to introduce Dr. Ajit Menon, who is a senior consultant interventional cardiologist with Lilavati Hospital, Bridgekandy Hospital, and Sir H.N. Reliance Foundation Hospital, Saifi Hospital, and Wokhart Hospital in South Bombay. He is a proud alumnus of the LTM Medical College and LTM General Hospital, from where he completed his MBBS in 1994 and his MD in 1998. Thereafter, he joined the Sir JJ Group of Hospitals and Grand Medical College for his DM degree in cardiology, which he completed in 1991. He stood first in the University of Mumbai for his DM cardiology examination. Thereafter, he joined as an associate at the PD Hinduja Hospital for a period of 4 years. He subsequently did the fellowship in investigational cardiology at the Royal Adelaide Hospital. He started his practice as a consultant cardiologist at Kambala Hill Hospital and Heart Institute in 1995, with whom he was associated till 2003. Subsequent to that, he joined Lilavati Hospital and Research Center as a consultant interventional cardiologist. His area of expertise lies in complex coronary interventions and various subsets of coronary PTCA. He has been invited to train interventional cardiologists in Perth in 2004 and 2006. He was awarded the fellowship of American College of Cardiology 2 years ago. He has been associated with various national and international trials as a co-investigator. He has been invited as a faculty for many Indian and international conferences. He is also a proctor for various complex coronary procedures, use of rotablators in coronary intervention and intracoronary imaging. May I present Dr. Ajit Menon to you.
Thank you, Dr. Vibhakar, for a very nice introduction. It's too much, and it's very humbling. Dr. Kamlesha, Dr. Jawahar, Dr. Anil Mehta, thank you very much, and I thank the CWAT Medical Association also for this opportunity. I'm going to talk. Whenever we talk about interventions, there is always a lot of debate on what exactly. It's very simple to say. You see a block, you do an angioplasty, and that's it. I don't think angioplasty is as simple as that. Angioplasty is probably much more complex than what we think about, and that needs. And over a period of years, we have learned how to manage patients with angioplasty without having to. Patients without having to do an angioplasty sometimes, and without having to send them for a bypass surgery, sometimes just on medical management, and when optimally to manage these patients. And with angioplasty getting more and more complex, we need to be sure that we deliver a result which is as good or better than a bypass surgery, and that's where optimization of the results comes into the picture. I hope you can see my slides. Can everyone see my slides?
Yes. Okay. Yes. Please go ahead.
So there are two. I will first talk about the physiology of coronary blood flow, and when we talk about physiology, we now have a modality which will tell us whether the lesion is significant or not, and that is basically something called as the fractional flow reserve. What is a fractional flow reserve? It is a lesion-specific physiological index determining the hemodynamic severity of intracoronary lesions. Therefore, FFR has the capacity to accurately identify lesions which are responsible for ischemia, which in many cases would have been undetected or not correctly assessed by angiography, or over-detected by angiography. Now, the point is, FFR is something which is measured at maximum hyperemia. What do we mean by hyperemia? It's basically a fully dilated and increased and maximal blood flow in the distal coronary blood. So it's the definition of FFR is the maximum achieved blood flow in a stenotic coronary artery divided by the maximum blood flow in the same artery without stenosis. So PD by PA is what is the fractional flow reserve. So the pressure difference beyond the block versus the pressure without any block or at the origin of the vessel. So that's what is the calculation of an FFR. And we know, and the standard ratios are FFR more than 0.8, you continue medical management. FFR 0.8 requires treatment either with stenting or a bypass surgery. The recommendation to use an FFR has been upgraded to a class 1A in the European Society guidelines, which means that it is a well-established modality of investigating coronary vessels before treating these vessels. And we also know with the various studies that have been there from with intracoronary physiology, which was of course courage was not with physiology, but it basically was a controversial study which said that there was a need, there was a PCI with optimal medical therapy was not superior to optimal medical therapy alone in chronic stable patients. Well, it did mean that there was a need for a stronger means to identify ischemia, because that study excluded a lot of patients. Differ is stenting in a non-ischemic lesion does not benefit the patient with stable coronary disease. The FAME was another study, was one of the largest studies, which showed that FFR had an advantage in assessing multivessel disease. So when you have multiple blockages, you don't have to necessarily say, oh, there are 5 blockages to send the patient for surgery or stent each of those vessels. You can do an FFR or an IFR in each of those vessels. And trust me, you'll find out that almost 40% of those lesions are non-significant. They don't need treatment. So you need to treat only the ischemic lesions and optimal medical therapy for non-ischemic lesions. The other argument is that block will increase. Well, you need to realize that if you bypass or stent a non-ischemic lesion, you're not gaining anything. There's always a chance of a restenosis. There's always a chance of a graft closure. So that's the reason why we need to be very specific in making sure that we treat only ischemic lesions. The FAME2 was another study which showed that FFR-guided PCI is superior to optimal medical therapy in stable patients. Well, what is the current evidence? The current evidence, which is a 5-year follow-up of the FAME study, showed that those patients who had undergone FFR-guided PCI compared to angiography alone PCI, FFR-guided multivessel PCI was much better in long-term survival and long-term results than a plain angio-guided PCI. Second, what about using non-hyperemic ratios? In terms of non-hyperemic ratios, there's something called as an IFR, there's something called as an RFR. I'll show that in the next few slides. But when you have these, it has been shown that at the end of 2 years, the achievement primary endpoint of the study, in terms of this study called the defined flare study, where it showed that IFR is equivalent to FFR. So either you do a resting study or you use a FFR, a hyperemic guided study. Both of these are functionally equivalent to a certain extent. So the FFR guided, again, there was another article which was published in the New England Journal of Medicine, the DANA-MEET3 multi study, which showed that the FFR guided in complete revascularization versus in infarct-related arteries was much more beneficial rather than only eyeballing these patients. Now, what is the benefit of a non-hyperemic pressure ratio? You would have heard about FFR, IFR, RFR. Well, what is IFR and what is RFR? IFR and RFR are instantaneous pressure ratios, which avoid the hyperemic agents. So this is one step beyond the FFR, where when you have multiple vessels, you don't have to give adenosine to all the vessels. So it can reduce patient discomfort, reduce procedural time, save cost, but it may lead to a wider adoption of physiologic lesion assessment in routine clinical practice. It basically depends on the algorithm or on a functional ratio. That there is something called as a wave-free interval during the diastolic phase of the cardiac cycle. So this is supposed to be a wave-free period, and the postulation is that the lowest PDPA ratio, occurs during this part of the cardiac cycle. And it averages 5 beats of data collection and tells you what is the IFR, or the instantaneous flow ratio. This is a patented Philips Volcano product. So the minimum resistance is during this period. There are clinical evidences to support it, that IFR and FFR agreement is almost 80%. In about 20%, there is a disagreement between the FFR and the IFR. And this is there on even a 5-year follow-up, and that disagreement of the FFR and IFR is at a specific ratio of the IFR between 0.86 to 0.89 or 0.91, where you may have a little infringement between the IFR and the FFR values. And at the again, like I said, the primary 2-year endpoint which was published last year, showed that IFR is equivalent to FFR as far as these ratios are concerned. Limitations of IFR, it requires sensitive landmarking of the pressure waveform. It assumes that maximum flow and minimal resistance occurs during a fixed part of diastole. Histologically requires ECG gating. So the newer technology, the newer this software does not require ECG gating, and that's distinctly an advantage. The question is, should we look only in diastole? Now, the ratio of PD by PA keeps changing throughout the cardiac cycle. So, are we looking only at diastole to see maximal flow and minimal resistance, or are there different areas? Now, there is a postulation again that in the right coronary artery, the maximum flow may occur in late systole or early diastole. And therefore, there was a concept of something called as a resting full cycle ratio, which is a patented St. Jude product. And it basically gives you an unbiased identification of the lowest PDPA in diastole systole. It is independent of the ECG, sensitive to small pressure changes during pullback, and a high dynamic range. So it calculates the lowest, the ratio throughout the cardiac cycle. That it basically errs on the fact that the lowest ratio may be anywhere in the cardiac cycle. So it takes a basic pressure, it takes a PD by PA and point by point, uses an anti-noise filter, and then it gives you the minimum value, which is the RFR. So this is there are clinical validations of the RFR also, and enough studies to show that RFR and IFR are equivalent in terms of diagnostic and clinical accuracy. There was a study called the Validated RFR study, which is a retrospective data of patients who underwent the IFR, and their waveforms were taken, and they were actually verified, and they were studied as far as the RFR values were concerned. It showed that the curves were absolutely the same, and the there was no difference between the RFR and the IFR values in those patients. So the sensitivity, specificity of RFR versus IFR is almost 97 to 98%. Having said that, like I said, in the right coronary artery, you may have a little bit of discordance where the RFR may have an advantage over an IFR, and that again, in case of any question, in case of any doubtful value, you always look at the FFR as the final as a final judge of the ratios. Now, if you look at the revalidated RFR study, which basically demonstrated that in the real world, RFR is equivalent to IFR in terms of most of the statistical areas. So, there are, like I said, there are various indices. There is a PDPA, there's an IFR, DPR, RFR, DFR. These are all flow ratios in diastole and throughout the cardiac cycle. Any of these flow cycles have shown a complete equivalence in terms of using an RFR or an IFR. But we don't use those in practice. In practice, what we use is an RFR, IFR, and of course an FFR. Now, I said that there was a bit of a discordance between FFR and IFR. Well, when you have a ratio of between 0.86 to 0.93 as far as the RFR or the IFR is concerned, you need to use an FFR to make sure that these ratios are significant or non-significant. This value is a bit of a long range, but anything beyond 0.93, there's definite that you don't need to treat. Anything below 0.86, you need to treat these patients. And as far as the FFR is concerned, the FFR cutoff values are 0.8. Again, 0.75 to 0.8 is a gray zone, but it's always better to treat a lesion below 0.8 and leave those beyond 0.8 on medical management. I will show you a few examples of this on the use of the FFR and the RFR in patients in a couple of patients. One, this is a gentleman who came with angina, and he had a very strongly positive stress test. This gentleman, we did an angiogram, but this is about 2 years ago. And if you look at the angiogram in the left system, you have the LAD coming off here, the diagonal coming off on top. And you can see that there is a lesion in the LAD here. There's a lesion in the diagonal, and the LAD is diseased from all the way from the ostium. Now, when you look at this, most of us will say, "Oh, this has got multiversal disease. Let's send the patient for surgery." Again, here you have the same lesions, lesion here, and a lesion in the thing. This optically and angiographically looks suitable for treatment, whether it's angioplasty or bypass surgery. And most of us would say that, oh, these are chronic, these are bifurcation lesions, these are extend into the left main, so let's send this patient for surgery. And this was the RCA lesion. Now the question was, do we treat all these three, or do we defer to treat the LAD diagonal based upon the findings? So we did a RFR of the LAD and diagonal, and surprisingly, the RFR of the LAD diagonal was 0.92. The RFR of the LAD was 0.96. So we did an FFR to the diagonal, which was again at 0.92, and the RFR in the proximal segment of the LAD was 0.97. So none of those lesions were clinically significant. So we treated the RCA, and this was the result after RCA stent. And surprisingly, now this gentleman, he got a stress test done in October. He hails from Rajasthan, from Madhya Pradesh, Bhopal. So he got a stress test done. 2 years down the line, his stress test is negative. He has no symptoms, and we have managed to conserve him as far as the LAD and diagonal is concerned. So we keep a regular follow-up on these patients. This is another gentleman who came from out of India just before the lockdown started. Just before the lockdown, 80 to 90% lesion in the osteoproximal PDA, had a high lateral wall MI, and there were lesions in the PDA. There was a lesion. There was a suspicious lesion in the LAD, which looked significant on angiography. Long segment, a suspicious lesion in the circumflex just after the origin of the posterior circumflex. And we know that he had a lateral wall MI, so this was probably the culprit lesion in terms of his anatomy. So we did an RFR to all these lesions. We did an RFR to the LAD 0.87 after nitroglycerin. Then we did an FFR to the LAD, which came as 0.82. So wherever the RFR value is in the gray zone, we always do a FFR. The FFR value came as 0.82. The RFR to the OM was positive at 0.85. So we decided to treat the obtuse marginal, and the RCA. And we have a follow-up, which is a 1 year follow-up from Oman right now, which is a negative stress test. This is another gentleman who came with an episode of an acute coronary syndrome about a month prior to coming to us. LAD showed a hazy-looking lesion in the proximal vessel. Looks significant on this value. Looks much more significant in the lateral view. If you can see this, if you can see this, it looks much more significant here. So this is a very tempting lesion as far as stenting is concerned. Right coronary was a non-dominant vessel. And this, if we didn't have any imaging, probably we would have gone ahead and stented this vessel. We did an RFR and an IFR on this patient, 0.89. PDP after NTG was 0.91, and of course with adenosine was 0.82. Now this patient almost has a 2 year follow-up on medical management. This is another gentleman, 71-year-old male. Again, RCA lesions. LAD lesion looks tempting again here, and a circumflex lesion, out of which the RCA physiological assessment showed an RFR of 0.93, FFR 0.91. The LAD physiological assessment 0.91 and 0.92. So again, no need to treat. We treated only the circumflex, and got it with a good result. Now, this is basically about the physiology of blood flow. When we talk about angioplasty today, we are talking about precision PCI. Precision angioplasty is because we are always given the flack that angioplasty is so simple. Just put a stent, get out what's there in it. the patient is fine. And then when a restenosis happens, the blame comes on us that, oh, this patient restenosis, it was not done properly. This patient should have gone for surgery. So we have gone one step ahead today. And now we make our decisions based upon intracoronary imaging as far as stenting or no stenting and how to stent the vessels are concerned. So functional testing tells us what lesions to treat, and intracoronary imaging tells us how to strategize and optimize an angioplasty. So very often we look at imaging from CT angiography, from various types of imaging. One is CT angiography, one is a coronary angiography, one is IVUS, and the last one, which is the latest, is OCT. So when we talk about, I'm going to talk more about OCT because it's one of the most dynamic imagings that we can have today in terms of imaging the vessel from inside and telling us how to plan the treatment and how to optimize the treatment. So in terms of strategizing the treatment, what does an OCT tell us? Why do we do an OCT? Why do we need an OCT? We don't need an OCT in all patients. Don't take me wrong. We don't need an OCT in all patients. We need OCTs in complex coronary procedures. In those lesions where we feel that these patients would probably benefit from imaging in terms of underestimation of calcium, underestimation of vessel size, etc. And that's where the OCT comes into the picture, because it can tell us the morphology of the lesion. Now, we have gone beyond just looking at the angiography on an angiographic, on a two-dimensional image, to looking at the lesion, whether the lesion is basically fibrous. It contains lipid, this black discoloration here that you see, the fallout here is a lipid-rich plaque. This is what is called a thin cap fibrous atheroma. You find that these are the atheromas which are very liable to rupture, and you can see a huge lipid core just below it. This black thing you see here, it's a huge lipid core just below a thin cap fibrous atheroma, and it can detect significant amount of calcium with a very circumscribed border. So this is the extent of calcium that is there in the single. You can see the calcium is superficial, whether it is deep, what is the arc of calcium, etc. It can tell you the length of the lesion. In the longitudinal view, it can tell you what is the length of the what is the length of the lesion. It can visualize the vessel diameters beyond and after. And of course, here I would like to tell you that when we stent, we stent from a normal segment to a normal segment. How do we detect the normal segment? I will tell you in the next few slides. You can measure the diameter of the vessel. Now, these diameters can be either from the external elastic lamina, which is seen here, to the external elastic lamina, or a luminal diameter, which is inside the lumen. So you can measure both these diameters. Now, if you take an external elastic lamina to the external elastic lamina, what is the need to measure the EEL? The EEL tells you the exact size of the vessel, and do not use a balloon beyond that size, because if you go beyond that size of the EEL, you will tend to rupture this vessel when you dilate these vessels. So that is the advantage of this machine, of this thing, telling you that this is the EEL diameter. Do not exceed it. So this is the external elastic lamina between the intima and the medium, and that's your plug point. It also tells you the calcific burden. It tells you whether it is low calcific burden, is moderate calcium. This is all calcium. This is all calcium here, and it also tells you, based upon the extent of calcific burden, whether you can do a direct stenting, semi-compliant balloon, NC scoring balloon, or you need to do a rotational atherectomy, intravascular lithotripsy, or a orbital atherectomy, which is not available in India. I'm sorry. So if a high calcium, that means if it is more than 180 degrees, more than 0.5 millimeters in thickness, and more than 5 millimeters in length, as far as the calcium is concerned, you need to use either of these devices, NC, IVL, cutting balloons, scoring balloons, or an atherectomy device to prepare a proper bed to deploy or to implant a stent. Otherwise, the stent will remain under expanded. So it tells you the length, and what happens is why do you need this to measure your length? Because it tells you what is a healthy segment. What is a healthy segment? You can see more than two-thirds, or at least 180 degrees of the EL in a segment. If you can see that, then it's a suitable landing zone. What is a non-suitable landing zone? If there's extensive calcium there, if there is a thin cap fibrous atheroma at the edge of the stent, or the large lipid core at the edge of the stent, which you cannot see on an angiogram. If either of these situations exist, trust me, these patients will come back with a restenosis or with an acute episode, which can be catastrophic. As long as you make sure that the landing zones are perfect, you land in a zone which is a clear zone, and there's nothing on the edges, you have a good result. What about the diameter? Like I said, there are two ways to measure the diameter, EL, and you can have this thing. The machine also has automatic measurements, so it'll tell you what the diameters are. Now, post angioplasty, why do you do an OCT? Well, to look at medial dissection, so you can have dissections at the end of the proximal stent edge. You need to address significant dissections. What about apposition? When the stent is well apposed, it tells you how much is the apposition. It tells you the stent is malapposed or not. What does malapposition do? Malapposition invites thrombosis. Malapposition invites restenosis. Stent expansion, well, you see the stent expanded on an angiography, but is it well expanded throughout the vessel? This calculates the stent expansion automatically and tells you whether it is 100% expanded or it is less than 80% expanded. Less than 80% is not acceptable. More than 90% is optimal. How do you detect medial dissections? You can see a dissection on this. You can see this flap over here. This is a medial dissection. On a cross-sectional view, you can see the dissection flap. This is from one of our patients only, where we had a dissection flap in the ostial in the proximal left main after putting a stent. And this is this is how you have any stent and any flap which is more than 60 degrees, dive limited and penetrating the medial layer, and greater than 1 quadrant arc. These dissections need to be treated. This is again a marker of this. It tells you this white marker on the machine tells you the stent is well apposed or not. And these are malapposed stents. You can see lying within the vessel. You leave it like this. These will tend to close off. Expansion, it will tell you the stent is well expanded or not. It tells you the area where it is not expanded, and it gives you a percentage of the expansion based upon whether the distal vessel or the proximal vessel. And you can go ahead with balloons and dilate these segments. So this is the Mld Max algorithm, which is there with the OCT. And basically, the reason why you use this is that under expansion of stents, or if you don't visualize under calcium, you can end up with stent under expansion, increased risk of complications, longer procedures because you struggle to get a device across. You will find that we can't get a stent across, we can't get a balloon across, the balloon doesn't cross the lesion, and you end up with much more longer screening times. Of course, you end up with much more stents. Various studies have shown that OCT-driven procedures do optimize the outcomes. And of course, all of you have heard of patients coming back in 2 years, 3 years with sudden stent thrombosis. You have stopped the aspirin and clopidogrel for some reason, whether for dental treatment or for some surgery, and suddenly these patients end up with late stent thrombosis. Well, a study of that has shown that most of these patients had either had uncovered struts or malapposed struts. And of course, there were cases of severe underexpansion also. And neoatherosclerosis definitely plays a part. And please understand that all stent thrombosis that come in is not a complication of the index procedure. There's something called as neoatherosclerosis, which happens inside the stent. That's a classical atherosclerotic phenomenon. And that atherosclerotic phenomenon, trust me, can rupture like any other plaque and can cause a stent thrombosis. So you need to understand that there are various physiologies or pathophysiologies of stent restenosis. Neoatherosclerosis is one of them. Neointimal hyperplasia is one of them. Thrombus formation, of course, is another major factor. There was a data which was released just 4 months ago, called the Light Lab data, which showed that OCT changes angiographic-based decisions in 88% of the lesions. And we were a part of an Indian study called the iOptico study, where we studied almost 500 plus patients with OCT before, after, and it also mirrored this. I don't have the slide of that data, but it mirrored exactly the same. Almost 85% of our patients had a cumulative impact on the on using an OCT, which changed the decision to treat, also changed the decisions as far as whether the stent was well expanded, whether there was any malapposition, the length of the stent, etc., etc. Just a couple of cases before I shut down. This is a young army major who was working at very high altitudes. He was in Kargil. He came in with history of acute onset breathlessness. He presented to another place somewhere in Punjab, and from there he came to Bombay. ECG showed an evolved anti-revolve MI by the time he came in. He was pretty young. But again, he started complaining of pain in the legs. So we had a Doppler done, which showed that he had deep vein thrombosis also. Now, this is a very common phenomenon apparently, where people working at very high altitudes develop coronary thrombosis as well as venous thrombosis. And we did a workup for all coagulopathies. We underwent an angiography. Now, based on this angiography, we said he's not going back to high altitude. So we thought that we will leave him on medical management. So we left him on medical management, and he came back after a year with progressive breathlessness. And he was a guy who used to run 5 kilometers. So he came back with breathlessness, repeated an angiogram, and we thought there was some disease progression. This time we decided that we'll take him up for a procedure. And you can see that this is a very complex looking lesion with a dissected plaque, and wiring would be a technical difficulty in these patients. So we managed to wire it with a little bit of difficulty, and we managed to get into a lumen, and we did an OCT. Now, you'll find that in the OCT, as you come onto the lesion part of it, you'll find multiple channels over here. And now we know that this wire is in the true lumen, because you have an intima, you have a proper intima on one side, and you have a proper layer of intima on the other side, coverage on the other side also. But again, you see these channels, these are all multiple channels which are highly suggestive of a recanalized septate vessel. But again, this compromises the blood flow because these are false lumens. This is the only true lumen here. So here it's a recanalized vessel, and this is how you look at it in the bifurcation mode. You can see the multiple channels here in the vessel. These are the images at different points. And here we could measure the length of the vessel. We could measure the diameter of the vessel. We could measure the size, the distal size of the vessel, the proximal size of the vessel. We know what size length stent to take. We know the length of the stent is about 28 millimeters. We went ahead with, since it was a recanalized vessel and a fibrotic one at that, because this is all fibrotic plaque. So we used a cutting scoring balloon, and we got a 3 millimeter stent inside, post-dilated, and we have a stent apposition indicator which shows the stent is well apposed, and this white thing on this shows the stent is well apposed. This part of the stent was a little malapposed, which we went in with a balloon and post-dilated again to get an optimal result. And this is this is another advantage of the OCT is that we can have a bifurcation view where this is the origin of the circumflex. So we know that one strut of the LAD stent is sitting across the origin of the circumflex, but the circumflex ostium is not compromised. And this was the final angiographic shoot. This is the last film, which is basically a young gentleman, non-diabetic, non-hypertensive, stress test in June 19 was negative. September 19, he got chest pain, did a CT angio, which showed a lesion in the proximal LAD, ramus, and a lesion in a minor plaque in the circumflex. So here we were deciding how to treat this patient, whether we should go send him for surgery or whether we should do an angioplasty. Well, we did an OCT into the ramus. This is the ramus stent, ramus OCT, which showed the ramus lesion is significant. This gentleman was not willing for surgery. So we decided that we will treat this patient with an angioplasty. We opened up the total occlusion of the LAD, used a balloon, and we decided that we will go in with a 2-stent technique using a Y stent at the origin of the at the distal left main. Well, we did bring both the stents into this thing, but then we realized that there was a significant plaque shift into the circumflex. So now we know that this guiding catheter will not take 3 stents. So we introduce another guiding catheter. You can see 2 guiding catheters here. So we introduce 2 guiding catheters, and we introduce the stent into the circumflex through the second guiding catheter. So we have 3 stents lying here. We optimize 3 stents, we deploy the 3 stents, but in the whole bargain, we realize that we have caused a small dissection flap here in the distal left main, which I think we should have expected, but we were already committed once we put the stents into the we opened up the LAD. We were already committed to an angioplasty. Well, we did an OCT again after that, and this is what the dissection in the left main looks like. So there's a dissection in the distal in the distal left main. So we can't leave this alone. This is again a two-dimensional. This is the bifurcation mode view. You can see 2 wires. You can see the origin of the circumflex. So what we did was we got a 4 millimeter stent into the distal left main. We deployed it. We recrossed into the ramus to keep, because the stent was in from the left main into the LAD. So we recrossed into the ramus through a balloon, through a wire and a balloon, the kissing balloon. And then we decided that we will do we got a good result. So let us finish off the procedure. But we realized something was wrong, and which is confirmed to the OCT, that the stent which was deployed in the distal left main had disappeared. We could not know where the stent was. You can see that this area is devoid of a stent. So this where the hell is the stent gone? Then we realized that because of all the manipulations and an undersizing of the stent had escaped backwards, but was still sitting in the left main because it was abutting against luckily with the guiding catheter. So we went in, did a 5 millimeter stent in the left main, and we got a excellent result. And now again, the advantage here with an OCT is that you can see the origins of the circumflex and the ramus. Both are clean and devoid of any stent struts. Why do I keep emphasizing on the clean part and the devoid of stent struts? Because if you have a situation like this, restenotic rates are going to be very low, because the more the struts coverage across the ostia, higher the restenosis. So that's we got a good result, and the patient is doing well. This is about 1.5 years post angioplasty, and he still comes for a follow-up. I think I'll end this over here, and thank you all very much, and thank you, Dr. Anil Mehta and team, Dr. Kamlesh Bhai, this entire CWAD Medical Association for giving me this opportunity. I'm really humbled by this, and thank you very, very much.
So thank you, Dr. Menon. And what I feel is that even every 2 years or 3 years, if we do a lecture on an angioplasty, there'll be something or the other new. A cutting edge technology has changed the entire procedures. So it was very informative. Thank you very much, Dr. Menon. And I will ask Dr. Jawahar to take it further. Dr. Jawahar, please.
Sorry. Thank you, Anil. It's a proud privilege to introduce Dr. Tala Miran, who's a USA board-certified consultant cardiologist in the Department of Advanced Cardiac Sciences and Heart Transplant at the Sir H.N. Reliance Foundation Hospital and Research Center. He's an alumni of the TNMC Nair, Mumbai of 2009. He did his MD Internal Medicine at the Johns Hopkins University, completing his fellowship in advanced heart failure, transplant cardiology, pulmonary hypertension, and mechanical circulatory support at the Allegheny General Hospital, Pittsburgh in the United States. He's currently an executive committee member of the Society for Heart Failure and Transplant in India. He also serves as the co-chair of the Heart-Lung Transplant Subcommittee of the Zonal Transplant Coordination Committee in Mumbai. He has multiple research papers and publications to his credit, and an excellent career in transplant cardiology. He will be speaking today on heart failure, a basic overview, and management pearls. Can I please invite Dr. Miran to take over from here? Thank you. Let me add, today is also his firstborn's first birthday, and he's taken his time off today, so thank you very much again.
Please unmute. Please unmute.
Thank you so much for those kind words and great introduction. Dr. Johar and team, Dr. Mehta and the entire CWARD IMA team for inviting me to deliver this talk. It's indeed a great privilege following, in line with greats such as Dr. Ajit Menon and, even following me, there is Dr. Hamdullah and Dr. Jumana who themselves are great speakers and experts in their field. So without further ado, we're going to talk about heart failure, a topic which is very near and dear to me. Are my slides visible?
Yes, yeah.
Okay, great. All right, so these are the topics that we are going to go over. I want to focus on the basics of heart failure and cardiomyopathy, and we will talk about medical therapy in a different light, meaning we'll try and understand how this medical therapy is related to the basic pathophysiology of heart failure and how we try to alter the, these different heart failure pathways by using these medications. And in the end, we'll also talk about what advanced heart failure is and when we should start thinking about referral to an advanced heart failure center. So let's start with the basic. What is the definition of heart failure? Basically, heart failure is a clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection of blood. So it could be a problem with ventricular relaxation or filling or pumping forward or ejection of blood. So, this is the most commonly accepted definition of heart failure. Heart failure with reduced ejection fraction, HFrEF, where the LVEF is less than 40%. Heart failure with preserved ejection fraction, where the LVEF is more than 50%. Recently, actually now it's more than 5 years, in 2016, the European Society of Cardiology started to introduce a new term called heart failure with mid-range ejection fraction for those who lie in this ejection fraction category of 40 to 50%. Why did they do that? When they introduced it, it was quite a controversial topic. Many cardiologists and even I actually think that this particular cohort falls in the same sort of spectrum of heart failure with reduced ejection fraction but they felt that the European Society of Cardiology felt like this needed to be identified and delineated simply because most of the studies that we have are either for EFs less than 40% or EFs more than 50%. So this 40 to 50% range was neglected, and so this was an initiative to try to invite more research on this topic. So that's why this new terminology. Another thing to understand is cardiomyopathy is not same as heart failure. You can have cardiomyopathy but not be in active heart failure. Cardiomyopathy is a disease of the myocardium associated with any cardiac dysfunction. This is a very old classification, 1995 WHO classification, where they differentiated between in cardiomyopathy in between dilated cardiomyopathy, restrictive cardiomyopathy, hypertrophic, arrhythmogenic right ventricular cardiomyopathy, and certain unclassified rarer forms such as non-compaction, stress-induced, or Takotsubo cardiomyopathy. We know that heart failure is a global pandemic. The numbers in US are staggering, nearly 6 million people. In India, there is a wide knowledge gap because of lack of good epidemiological studies looking mainly at this heart failure population. However, knowing what the risk factors are, such as rheumatic heart disease, hypertension, and diabetes, there are certain estimates, and these estimates are over here, as you can see, between 1.3 to 23 million people with heart failure in India. It's also quickly affecting the young ones, the so-to-call the bread earners of the society. This was a article from around 4 years ago in a financial newspaper in India, which I thought was quite interesting. Quickly moving on, everyone that manages heart failure should know this. These are the ACC, the American College of Cardiology, American Heart Association stages of heart failure. There are several different categories: stage A, stage B, stage C, and stage D. We'll start from the left. Stage A is when you have when you're at risk for heart failure, but your echocardiogram is absolutely normal, meaning you don't have any structural disease that shows up on the echocardiogram. So, in this case, you could think of maybe diabetes, hypertension. So you want to make sure that these risk factors are well controlled at this stage. So that's the proposed therapy at the bottom. Stage B, moving on, you have those risk factors, but now you started to manifest with some structural changes on the echocardiogram. So say, let's see, if you have uncontrolled hypertension and you have left ventricular hypertrophy over the years because your hypertension is not well controlled, but you still don't have any heart failure symptoms. Again, over here at this stage, the proposed therapies are even, more stricter control of your medications, make sure those risk factors are very optimally optimized. Stage C, now this is the stage where we see our patients coming to the clinic. So you have structural disease and start having heart failure symptoms. We'll talk about what the proposed therapies are. This is what the remaining presentation is dedicated to, treating stage C, heart failure with reduced ejection fraction. And then you move on to stage D, which is advanced heart failure, where the patients become refractory to medical therapy, have repeated heart failure hospitalizations. And at this stage, what you're left with is limited options between mechanical circulatory support, and advanced heart transplantation, and in some selective cases, continuous home inotrope infusions. This, I believe, everyone is well familiar with, the New York Heart Failure classification of heart failure, going from class 1 to class 4. Class 1, where you have no limitations in your physical activity, no symptoms at all, and class 4, where you have severe limitations and you have discomfort even at rest and speaking a few sentences. So what are the common risk factors for heart failure? Hypertension and atherosclerotic disease and diabetes are the big three in the Western world. In India, when you think about the Indian scenario, you also have to think about rheumatic heart disease and all those uncorrected rheumatic heart disease who later present to you with LV failure or RV failure. Metabolic syndrome is also an important risk factor. Certain other risk factors, as you can see here, I would like to highlight a few that are quite important. Familial cardiomyopathy, especially non-compaction cardiomyopathy. Why I like to raise this is because this is a very this diagnosis comes with a very poor prognosis and can come with a very high chance of sudden cardiac death. So, I have seen several members of a family, young people in their 20s, who have lost their younger brothers and now are coming in because they know they carry that same diagnosis and they want to do something about it. So non-compaction cardiomyopathy should never be taken lightly. Endocrine hormone abnormalities, thyroid disorders, growth hormone deficiencies, acromegaly, all of these can also lead to cardiomyopathy. Alcohol and cancer chemotherapy is quite commonly seen in the community these days. Vitamin D deficiency is not very common in the adult. Vitamin D deficiency leading to cardiomyopathy is not as common in the adults as it is in the pediatrics. Every 6 months or so, you do see a few case reports of pediatric cardiomyopathies being treated and successfully treated just with vitamin D repletion. Some other risk factors: uncontrolled tachycardia over a long time. Viral cardiomyopathy and myocarditis is very, very, very common, especially in the flu season. Peripartum cardiomyopathy, iron overload, and then other certain rarer conditions such as amyloidosis, sarcoidosis, stress-induced cardiomyopathy, or Takotsubo cardiomyopathy. Now, when you think about symptoms of heart failure, I like to think of them I like to divide them into two different parts. There's symptoms of left heart failure and symptoms of right heart failure. So when you think about left heart failure, there is either a problem with the pumping or the relaxation. So you could have reduced ejection fraction or advanced degree of diastolic dysfunction, which eventually also leads to loss of left atrial compliance. So what does that lead to? Eventually passive backward transmission of left-sided filling pressures onto the lungs, and the lungs start filling up with fluid. So then that gives you dyspnea with varying grades, cough, orthopnea, which is dyspnea, which gets worse in a supine position. You get episodes of paroxysmal nocturnal dyspnea, palpitations, dizziness, fatigue, And then in very advanced stages where because of low cardiac output, there is low cerebral perfusion, people tend to get dizziness and even memory lapses. Moving on, symptoms of right heart failure are because of this, again, passive transmission of pressures backwards into the neck veins and then onto the liver and your gut and the lower extremities. So you see distended neck veins because of gut edema and intestinal swelling. You have loss of appetite, anorexia, abdominal distension because of ascites, leg swelling. Because of congestive hepatopathy, you tend to develop icterus. In very, very advanced stages, patients tend to lose weight, loss of protein mass, and that's called cardiac cachexia. You see very classical bitemporal muscle wasting. So this is how think about the patients. When I try to ask them questions about symptoms of heart failure, in my mind, I'm trying to ask them questions to try to distinguish whether they have more left heart failure symptoms or right heart failure symptoms or a combination of both. Diagnosis, most important thing is a good history and physical examination. Once you have your physical examination and history, you know that this patient probably has heart failure. You back it up with biomarkers because they help in follow-up of these patients and also help to prognosticate these patients. So most commonly used biomarkers that we use in the community are the natriuretic peptides, so BNP, pro-BNP, NT-proBNP, and cardiac troponins. There's a caveat that one must always remember, and it's quite common to, especially in morbidly obese individuals with a lot of peripheral adiposity. These patients tend to have falsely low NT-proBNP levels. Even though they are in active heart failure, you expect their NT-proBNPs to be in the thousands. Their levels would probably be in the low hundreds because the adipose tissue has a lot of receptors for this natriuretic peptide. So all of the natriuretic peptides go bind to the adipose tissue. Hence, the levels that you're monitoring in the serum are not elevated. Then you also want to know what is the condition of the end organs, the renal function test, the liver function test, and look at their thyroid profile, vitamin D levels. A very important thing is the serum iron profile, and we'll talk about why it is in a couple of slides later. Moving on, once you've done your basic blood test, history, physical examination, you need to confirm your diagnosis by doing a 2D echocardiogram, which would be a detailed report which has all the left ventricular size metrics, right ventricular size metrics, how the valves are doing, what are the sizes of the atria, how is the diastology parameters. And then in select cases, not every case needs a cardiac MRI or a cardiac PET scan, but in select cases, you want to do a cardiac MRI and a cardiac PET scan. Cardiac MRI is mostly in patients where most commonly used these days to look at viability, where you say someone has had acute coronary syndrome and the LVEF is low and the muscle seems thinned out on the echocardiogram. The MRI gives us more characteristics about the myocardium and tells us if there is feasibility or any benefit in trying to revascularize. So viability assessment, and also very important in these rarer conditions of infiltrative cardiomyopathy, such as amyloidosis, sarcoidosis, non-compaction cardiomyopathy, and ARVD. Once you have looked at your imaging, confirm your diagnosis, depending on the risk factors, you may or you may not want to do a coronary angiogram. A young person in their early 20s with no risk factors, lifelong non-smoker, no family history of coronary disease, and a clear-cut, say a viral prodrome starting before the heart failure symptoms, would definitely not need a coronary angiogram. Whereas a 50-year-old diabetic with new onset heart failure, with new reduction in left ventricular ejection fraction should definitely get a coronary angiogram to define the coronary anatomy. Right heart catheterization, Swan-Ganz catheterization are only indicated in certain advanced heart failure cases. And endomyocardial biopsy also comes indicated only in a very small niche subgroup of patients. Very rarely in adult patients, except for when you're suspecting cardiac amyloidosis or certain rarer conditions such as acute lymphocytic myocarditis or eosinophilic myocarditis. Rarely does it change your diagnosis, especially if done for a post-viral sort of cardiomyopathy picture. But in amyloidosis, definitely it can change your management as well as prognosis. We are going to now talk about management of heart failure with medical therapy, and we're going to talk about it with respect to the different heart failure pathways. So there are 4 main heart failure pathways that we are trying to alter at all times with different medications. The first one that comes to mind when you talk about heart failure pathways is the RAS, the renin angiotensin system. I know everyone is getting sort of a flashback from their medical school, but I'll just go over it in a quick way. Angiotensinogen is produced by the liver. The renin, which is secreted by the kidney, converts the angiotensinogen to angiotensin 1. Angiotensin 1 is converted by ACE, which is an enzyme secreted in the lungs, to angiotensin 2. And then angiotensin 2 has all these downstream effects on the blood vessels, where it causes smooth muscle cell hypertrophy, vasoconstriction, endothelin secretion on the kidneys. It causes mainly sodium and water retention and efferent arteriolar vasoconstriction. On the heart, it can cause cellular hypertrophy, and in the end stages causes myocardial apoptosis and fibrosis. It has effects on the adrenal glands. It leads to secretion of aldosterone, and also stimulates vasopressin secretion by acting on the brain. So what are the RAS pathway modulators that we know? We know the ACE inhibitors, which are time-tested: enalapril, ramipril, lisinopril. Angiotensin receptor blockers. I've just put on the common ones that we tend to use: valsartan, losartan, telmisartan, and olmesartan. And then you have the mineralocorticoid receptor antagonists, the spironolactone and the eplerenone. The second pathway that I would like to highlight is the sympathetic nervous system pathway. The sympathetic nervous system has a lot of deleterious effects on the heart. It itself can cause myocyte hypertrophy, myocyte necrosis, and fibrosis, can lead to increased arrhythmias, and impair the diastolic and systolic function on the kidneys. More reabsorption of sodium and more fluid retention increases the renin release as well, and decreases your response to the natriuretic peptides. And on the blood vessels, it causes, again, hypertrophy as well as neurogenic vasoconstriction. So you obviously want to protect your kidneys, heart, and your blood vessels from all these deleterious effects of upregulation of the sympathetic nervous system. And the way you do that is by using beta blockers. Very particularly in heart failure, the recommendations and the large body of evidence is to use either one of these 3 beta blockers. And I've just put the name of the trials that led to their FDA approval subsequently. So the CIBIS-2 trial led to the approval of bisoprolol. This is the starting dose, 1.25 milligrams OD, going up to a max of 10 milligrams OD. The MERIT-HF trial was responsible for metoprolol succinate. So this is the long-acting form of metoprolol, not the tartrate. This is the succinate, your MET-XL, starting from 12.5 milligrams to 100 milligrams per day. And the Copernicus trial led to a carvedilol coming into the picture, going from a dose of 3.125 milligrams VD to 12.5 milligrams VD. Now, this was the relatively new kid on the block. This is the new pathway modulators that we're going to talk about. This is the neprilysin pathway. Everyone has, may have heard about sacubitril valsartan combination, which is marketed in India commonly as either Sigmus or Bimada. So why is this neprilysin pathway so important? So what we know from basic science research is, in heart failure with reduced ejection fraction, as we already talked about, there is activation of the RAS system at the bottom, and there is activation of the natriuretic peptide system on the top here. So the natriuretic peptides are actually beneficial. They lead to vasodilation and natriuresis. What happens is neprilysin is an enzyme which breaks down these natriuretic peptides. So if you inhibit this, the neprilysin with a molecule, then you have the beneficial effect of the natriuretic peptides. Also, what happens is the natriuretic peptides have an inhibitory effect on renin release from the kidney. So it acts on both ways. It acts on the neprilysin pathway as well as on the renin-angiotensin pathway. So that's how the sacubitril the sacubitril is the neprilysin inhibitor came to mind. So one must also note that sacubitril also inhibits angiotensin 2. So if you just use sacubitril alone, there will be a sort of increase in levels of renin and angiotensinogen. That's why you have to combine the neprilysin inhibitor with an angiotensin receptor blocker such as valsartan in this case. So that's the sacubitril valsartan combination. Now the last pathway is the Sglt2 inhibition. The latest kids on the block in heart failure, which have really gained prominence in the last year, 1 year, 1 year and a half. The two molecules that we know of are empagliflozin and canagliflozin. They're quite simple molecules to use, meaning the medication is a fixed dose medication. You start at 10 milligrams OD, and that's it. You leave the patients for heart failure and cardiomyopathy indication. So, what does the SGLT2 inhibition does? So, initially, when these medications were sort of made, they were thought as primarily anti-diabetic medications, and they acted by promoting glucosuria, so reducing your blood glucose levels. But later on, in the initial diabetes trials, they realized that there was a quite a significant benefit in the cardiovascular patients, especially in the patients with heart failure, where they had improved functional class and lesser heart failure hospitalizations. That led to at least 3 or 4 more pivotal landmark SGLT2 inhibitor trials over the last 2 years, and has led to their use and inclusion in the latest heart failure guidelines. So by promoting glucosuria, that is the primary action. Then it also acts on the liver. It increases lipolysis and gluconeogenesis, acts on the kidneys, and prevents the progression of fibrosis. There is good evidence to show how it can be used in CKD patients, provided the GFR is more than 30, and in trying to delay the progression of chronic kidney disease. It also acts on the heart by promoting ketone body utilization, which is a much better way to produce ATP for the heart. So in essence, on the heart, it decreases both the preload and the afterload. There is a decrease in the systolic blood pressure, decrease in arterial stiffness, volume of blood, and the hyperglycemia, the blood sugar levels goes down, and the insulin resistance improves over time. So that's why the SGLT2 inhibitors. Now, in addition to these 4 pathways, there are certain other supportive medications that we commonly use in our heart failure patients. Everyone knows about diuretics. You can't simply just put your cardiomyopathy and heart failure patients on these 4 medications and not treat their leg edema, not treat their paroxysmal nocturnal dyspnea and the orthopnea. So you have to use diuretics for symptom relief. Digoxin in selective cases, provided their renal function is normal. I tend to avoid digoxin in elderly patients, and whenever I use digoxin for cardiomyopathy, I make sure that I'm monitoring their serum digoxin levels at least every 6 months, and this is the optimal serum digoxin trough level that is advisable for cardiomyopathy patients between 0.5 to 0.9. Because the patients are on diuretics, you need to make sure that their electrolytes are repleted, especially patients with low ejection fraction who are anyways predisposed to cardiac arrhythmia. So to prevent that, patients may need some potassium repletion. Now, I talked about doing an iron profile on patients with cardiomyopathy. There's 2 big trials about 7 to 8 years ago, one of them being ROSE-HF, which looked at cardiomyopathy patients, irrespective of what their hemoglobin levels were, and looking at the ferritin and transferrin saturation. If their ferritin levels are less than 100, or if they're between 100 to 300 with a transferrin saturation of less than 20%, then they qualify for use of IV iron. Namely, the molecule that has been used in most of the trials is IV ferric carboxy maltase, that's your FCM. total dose of 1 grams, which you can split over a week. So 500 milligrams now, and maybe after 3 days or maybe after a week, you can give another dose of IV iron. That has shown to reduce heart failure in hospitalization, as well as improve the functional capacity of the patient. So these are the heart failure supportive therapies in addition to the main guideline directed therapy. Now, very exciting new update just popped up just last month. This is a publication from 2021. This is not in the guidelines, but this is an expert consensus pathway that is recommended by ACC and AHA. So for all patients with heart failure with reduced ejection fraction and stage ACC, AHA stage C, the initial treatment is an ARNI meaning your sacubitril valsartan, or an ACE inhibitor, or an ARB. They over here in brackets mention that ARNI is preferred because of the significantly better outcomes with ARNI on the ARNI trials. So upfront, you are adding an ARNI combined with an evidence-based beta blockers. Remember those 3 beta blockers with a diuretic agent on an as-needed basis. And then you decide what else to add from here. So then if your patients have a GFR of more than 30, or a creatinine of less than 2.5 if they are males, or less than 2 in females, then you would want to add an aldosterone antagonist, either an eplerenone or spironolactone. You then move on, and you can, again, if you meet their eGFR criteria of at least 30 for canagliflozin or 20 for empagliflozin, you can add the SGLT2 inhibitors. Preferably, if you were to ask me what I would do, what would I add first between an ARNI and a beta blocker and an aldosterone antagonist and an SGLT2 inhibitor, I would say it depends on what their initial presentation is. If they're coming on with a cardiogenic shock, active pulmonary edema kind of picture, I would first focus on removing the extra volume and simultaneously adding a low dose ARNI and delaying the beta blockers for later. If the patients are coming in a more drier state, just an OPD visit, and you diagnose them with this heart failure with reduced ejection fraction, then I would probably go in for a beta blocker and ARNI combination up front, add aldactone and maybe an SGLT2 inhibitor after 3 to 4 weeks. The teaching is that even if the patients are in what you think is stable heart failure, they are never low risk. You always at every given moment should try to optimize and maximize the guideline directed medical therapy. So when you look at a patient with with stable heart failure, you are trying to weigh the potential risk of attempting to escalate the guideline directed medical therapy. So what are the potential risks? You can have side effects, you can have adverse events from that. What are the potential risk of not escalating these guideline directed medical therapy in an eligible patient? Is you are decreasing their survival, you're increasing their risk of hospitalizations, you're increasing the risk of worsening the functional status, and overall decreasing the quality of life. So at all given chances that you have, try to maximize your guideline directed medical therapy. Always screen their list of medications to make sure they're not taking any medications that are not beneficial to them. Very commonly I see amlodipine or clinidipine on patients list, but no beta blockers and no ARBs or sacubitril valsartan. That I feel is a practice that should be abandoned, and we should aggressively look at when can I introduce these molecules and how can I increase the doses of these medications. Because look at this table now. This is the cumulative impact of evidence-based heart failure therapies in patients with reduced EF. So if this is how much effect you will have on their relative risk and 2-year mortality just by using ACE inhibitors, ARBs alone, just by using beta blockers, just by using aldosterone antagonists, using ARNIs and using SGLT2 inhibitors. They say that the cumulative risk reduction, if all these therapies are used, is a relative risk reduction of 74% with a number needed to treat of only 3.9. That's way, way, way better than any of the currently existing recommendations that we have in guidelines, irrespective of the the pathology that you are considering. So always try to maximize medical therapy. Very quickly, I think I just have around 4 or 5 slides left. You know, there are many sort of finer points about when defibrillators should be used or when they should not be used. I've just sort of condensed it and simplified it here. You know, when your ejection fraction is less than 35, they should have symptomatic heart failure, NYHA functional class 2 or greater. And most importantly, they should already be on maximal medical therapy. So in ischemic cardiomyopathies, they should have had a trial of maximally tolerated medical therapy for at least 40 days, and in non-ischemics for at least 90 days. Only then you would give them an enough benefit with the defibrillators. This is a picture, this ECG is a picture which everyone should have ingrained in their brains. This is an ECG with a left bundle branch block. If your patients with low ejection fractions come in with this kind of picture, always think about cardiac resynchronization therapy. It's a great tool. I always get very excited when my patients come in with this ECG, because I can tell them with more confidence that they will benefit from cardiac resynchronization therapy with biventricular pacing or his bundle pacing or left bundle pacing. I've seen remarkable results where the patients have improved their EFs from 15% to nearly normal of around 45 to 50% over a matter of 6 months. Obviously, on a background of guideline directed medical therapy. So please always look at your patient's ECGs. Then moving on, what is advanced heart failure? Try to explain this in this slide from an Indian perspective. There's many metrics that the ACC/HA and the European guidelines look at, but to simplify it, when you're looking at patients in the community, when do you think these patients should be referred to an advanced heart failure center? If they start having recurrent heart failure hospitalizations, each hospitalization, remember, increases your risk of subsequent hospitalization by 30% in that year. If the echocardiogram is showing progressive negative LV remodeling despite medical therapy. What do I mean by negative LV remodeling? The LV size is getting bigger, the mitral regurgitation is getting worse, RV dysfunction is getting worse, and to top it all with that, the pulmonary pressures are getting worse despite medical therapy. If for some reason they cannot tolerate evidence-based medical therapy due to hypotension or persistent hyperkalemia or renal dysfunction, all of these should be red flag signs where you should start thinking about referral to an advanced heart failure center. This is a very important sort of schematic that I always talk about and I show to my patients when they come to the heart failure clinic. This is heart failure is a progressive condition, and this progress can only be modulated by the evidence-based medical therapy that we have seen. Once, as time goes on and as their medical condition worsens, their frequency of hospitalization increases. As you can see, these dip downs become more frequent as time passes, and with each dip down, the recovery is never back to this original cardiac function that we started with. It's always lower. So you want to break this spiral with medications, and if you can't, then you start thinking about advanced heart failure options. Timing of referral is key. Very important quote from the great writer William Shakespeare: better 3 hours too soon than a minute too late. Remember that the older patients have no reserves, and the younger patients tend to hide their symptoms. So always be very vigilant about your history taking in these population. Very quickly, last 2 slides, I wanted to talk about our team transplant outcomes. As you know, we have an advanced heart failure transplant and mechanical circulatory support team at Sir H.N. Reliance Foundation Hospital. Over the last around 4.5 to 5 years, we've done upwards of 120 transplants now. The pediatric, out of which the pediatrics were 21, with an excellent survival of 95%. And in the adult population, our 2-year survival is around 80%, which is comparable to the international data and the median survival that is quoted in the international literature. We recently had this published our outcomes with in the Indian Journal of Thoracic and Cardiovascular Surgery. This was just published last month, where we published our outcomes of temporary mechanical circulatory support and our outcomes based on that. Last slide, this is in summary. Remember to differentiate between heart failure and cardiomyopathy. Remember, good history and physical exam is key in diagnosis, which is aided by your echocardiogram. Remember the 4 pathways. Evidence-based medical therapy is always the first step in treating cardiomyopathy patients. Cardiac resynchronization therapy in appropriately selected patients with left bundle branch block reduces mortality, and timely referral to an advanced heart failure center is key. With this, I would like to end. Thank you again for everyone for their patient listening. Thank you.
Thank you, Dr. Menon. I think the hallmark of a great expert and a good teacher is how he makes the complex subject most easy to understand. And I think you've been very good to that task. Thank you so much. Also, the fact that as general practitioners, we are bombarded with guidelines every day. And I think there's a point, we've reached a point where we need guidelines for guidelines. I think this comes as a breath of fresh air. Thank you. I'll now invite Dr. Jitesh Mehta to come forward and introduce Dr. Hamdule for the next session.
Yeah, hello. Good afternoon, everyone. Hi, Dr. Hamdule, Dr. Kamlesh, Dr. Jawahar, Dr. Anil Mehta. Friends, Dr. Hamdule is the Director of Cardiovascular, Cardiothoracic and Vascular Surgery at Global Hospital, Parel. He graduated from VM Medical College, Solapur, after which he did his MCH in Cardiac Surgery from Lokmanya Tilak Memorial Hospital, Tyne. He took further training from the Royal Liverpool Children's Hospital and the Manchester Royal Infirmary Hospital, UK. He did his clinical fellowship from Toronto General Hospital, Canada. He is known for his innovations and skills in cardiac surgery, and the fact that he has attended more than 7,000 cardiac surgeries up till now speaks volumes of his vast experience. On 24th of August 2017, Dr. Hamdule did a successful heart transplant surgery at Global Hospital. Today, Dr. Hamdule will be talking on the surgical management of heart failure and left ventricular assisted device. I invite Dr. Hamdule, please.
Thank you, Dr. Jitesh, and I especially thank Dr. Jawahar, Dr. Anil Mehta to give me an opportunity to speak on this August forum. It's always a privilege to talk on this forum, and I'm going to talk on a subject which still has to take a big lead into our Indian scenario, and which has come and which can be a great asset in management of heart failure. Whenever it comes to heart failure, the first question is what a surgeon is doing into this forum. And it's always a very late entry for a surgeon into this problem of heart failure. But having said that, can I have a control of the slides, or can be made next? Just to correct, I have put up my own setup at Masina Hospital called Masina Heart Institute. And it's been 2 years, and we are now doing a fairly good work and doing all sort of works. Our cath lab is picking up on a lot of high innovation technology work, as well as we are being registered as a heart transplant unit. We have already done a heart transplant recently into this hospital, and we have been registering quite a few, and we have a dedicated heart failure clinic in this Masina Heart Institute. So having said that, Dr. Tala has done a fairly good job at presenting this complex disease into such a simple slides, which I think I have also understood a few things, Mihan, after listening to you. And I'm sure most of you will benefit. Now, I'm just going to start where Tala has left, and we all understand that this is a monster which is coming up, and it's a serious disease. If you look at, because the basic epidemiology is well controlled and slated in American data, so nearly 6.2 million people are affected with heart failure. It's a huge number. And if you compare vis-a-vis to our Indian population, it is going to be a much bigger problem for our state, eating away a lot of our resources. And it's nearly 6 lakhs patients have been, from this 6.2 millions have already crossed into an advanced heart failure state that accounts nearly 10%. In Indian scenario, I have not put up the Indian data. Simple reason is, as Tala said, that we don't have a robust data to exactly pinpoint what the exact problem in our country is. But taking a leaf from the United States data, it shows that it's a big problem. And having said this, if you see that anytime a patient of a heart failure comes with hospitalization, then suddenly the median survival of this patient drops down to less than 2.4 years, which is nearly 2.5 years, which just flies off like that. In COVID, we just crossed over a year without knowing. So this is how this is eating away our population, and we have more than 350,000, 3.5 lakh death in United States itself from heart failure. Next slide, please. Now, this is what, if you see that over a period of time after 2012 and 14, maybe there are more numbers of patients which have been diagnosed. We are looking a steady rise in the death from heart failure, nearly going up, touching up to 3.5 lakhs death in just 2017. So there's a sharp increase of 24% in the deaths that we are seeing from heart failure. Next, please. This again gives us how what Tala was saying about every hospitalization can never take the patient back to its initial stages. And this shows the need for quick diagnosis of heart failure and start treating them before they start requiring, before they start needing hospitalizations. So if you see that a patient with the first hospitalization, the survival is 2.5 years. And by the fourth hospitalizations, it just drops to half a year. So we can understand the severity this quickly heart failure takes a form of, and we losing our precious patient in such a short time. Next, please. This also has been explained, but then there's going to be some repetition because I am going to take through this to bring it to a point why Lvads are an important armamentarium in management. This was more simplified image what Tala had put up. I have put it into a different perspective. We have stages of AHA as stage A, B, C, D, and we have an NYHA class 1, 2, 3, 4. And if you start combining these 2, 3, I think there are always stage 1 where they are just trying, we should pick up the factors which are going to end up into heart failure and start treating, like treating hypertension, diabetes, and dyslipidemia with ACE inhibitors or ARBs. Early introduction of this can reduce the risk of this patient slipping into worse situations like heart failure in upper classes. If they get into class 1, then we quickly introduce them of ACE inhibitors. The recent thing that we start now, don't waste our time. We can always go, and the patient is affording in with ARNIs. Then as the patient moves into class 2, then we go into sodium restriction, diuretics, digoxin, and ACE inhibitors and beta blockers. As we are moving, as the patient moves into other stage, like stage 3, into more severe form of heart failure, then we are looking at now revascularizing, or if there is a mitral valve problem, then we need to fix it, because we have always learned MR begets MR. That's a very common sentence we read. So here an MR will lead to more heart failure problems. So we need to fix this MR, reduce it to get the treatment of this patient back into lower stages or lower class. So if the patient is ischemic, then we go in and try to give him a revascularization with CABG or plasties. Then think about aldosterone antagonist, or now what we have put up as the SGLT2s or ARNIs. Where the surgeon comes in is the patients coming in repeatedly into the hospital and has become a very frustrating point for a physician or a cardiologist to manage these patients. Then we have to start looking beyond medical management. They are on high dose of inotropes. They have slipped into class 4, class 3B or class 4. Then we are looking at options which are called as ventricular assist device or transplantation. Currently, we always think about now, because transplantations has generated a little bit of interest into our city and into our country. though a little later than what we see in Western countries. But then there is something which has been ignored, maybe because of the cost factor, is the ventricular assist device, which are also a very important armamentarium in management of these patients and giving them a better life. Next, please. So these are certain devices which has also been covered. We talk about defibrillator because these patients have a propensity to get into VTAC and into arrhythmia. So these need to be converted in time. So we have to put them on implantable cardioverters. Then there is a synchronization therapy, what Tala also mentioned about. We can just sync the beating of the two ventricles, and the ejection fraction can have a dramatic effect by increasing from 10-15% to maybe 30-40%, and can give a great relief to this patient. So if you start introducing these therapies on the right time, then we can really treat heart failure in much better ways. And this is an expensive therapy called as mitral clip for because these patients are very high risk to go in for open surgical mitral valve corrections. And then the shortcut is what we talk about, the transcatheter mitral valve mitral clips. We still have to get an FDA approval in more widely used into our country, and also the cost is humongous in this cases for this device. But then this is one of the factors which can help us to control mitral regurgitation in patients and treat heart failure. Then there are devices called as PA pressure monitoring system. At home, we can monitor the PA pressures, which are an indicators how the heart failure is moving, and then start treating PA pressures and reducing the lung pressures inside, so that there's a less pressure on the heart, which can pump against and treat these patients. And ultimately, I'm going to talk about this left ventricular assist device. They are ventricular assist device. They come under the headings of mechanical circulatory supports. And I'm looking at a big market, or we can look at a big way this device will be used in future, maybe with cost little coming down, with maybe made in India prototypes coming into the market. We'll have better usage of this and more widely used assist device. So we better be prepared, have more knowledge about which patients are candidates for left ventricular assist device, which is the main theme of my today's talk. Next talk, please. So we always knew till now, or more focus point is what is the end stage therapy. When the heart has really given up, there is hardly any scope for further pulling on with the medical treatment, and we know that we are going to lose this patient sooner or later. Then there is still a ray of hope for such patients. And as I said recently, because of more pushing in for organ donation into our city and in our country, we hear more and more about heart transplants. And but then before even we think about heart transplant, there is another therapy as mechanical circulatory support or ventricular assist device. I say LVAD because it focuses more on supporting the left ventricle. So that's why we are talking about left ventricular assist device. Next, please. So this is how the current scenario internationally is about. This is a famous slide you'll see in every patient, every speaker who has been talking about heart transplant, and how it is now more or less stabilized. Our graphs are not moving much, and this is because whether it is North America or Europe, there is a steady of the heart transplant program there. And the main reason for this is availability of donor heart. The number of patients are increasing, but the transplant are just remaining the same. So what happens to that extra load of patients that we are now diagnosing and treating, and what options we have for them? So we have to think seriously about other options, maybe mechanical, maybe artificial, with which we can take care of this heart failure epidemic. Next, please. These are another slide, but we see how the introduction of left assist device ventricular assist device has come into play now with a gradual increase in their use from December 5 to December 17 data that we have picked up from Sglt, that now there is more and more usage of ventricular assist device or mechanical support system. Next, please. So why at all we are talking about ventricular assist device when we have a much more natural therapy for this thing? The reason is simple: is heart transplants. What we are looking at. We don't get donor heart, so there is a problem with organ availability. There is what we are looking at patients with advanced age coming in for heart transplant with heart failure. So they are not a candidate for heart transplant. So what happens to them? Then there are patients which come pretty late with high pulmonary vascular resistance. So they are also not candidate for heart transplant. As we are looking at higher age group over a period of time, it get better survival. Then there are patients with a lot of comorbidities which also don't classify for or qualify for heart transplant with active systemic infection. So these are actually contraindications for heart transplant, which becomes an indications for our ventricular assist device. Next, please. So when we talk about ventricular assist device, it's not that each and any patient who is walking in is a candidate for ventricular assist device. I will take you through how we are going to identify patients for first of all with advanced heart failure and requiring ventricular assist device. Next, please. So they are all based upon our European guidelines of 2016. Next. And again, before I venture into what are the indications for ventricular assist device, I'll take you through some terminologies. So which we'll be hearing maybe when a general practitioner talks to his physician or a cardiologist or a surgeon, he'll be talking in this term. It is something as a bridge to decision. It's a bridge to candidacy, bridge to transplant. So what is this all bridge we are talking about? So in short, I will explain to you what exactly all this means. So suppose a patient of a heart failure walks into your clinic and he is unstable. So we have to still decide about what next therapy has to be given, whether he's a candidate for heart failure, whether he's a candidate for even ventricular assist device. So here we have to buy some time. So we have to take some decision about his permanent therapy. So here we use some mechanical circulatory support system. We must all have heard about Ecmos. So what is this ECMO used for? In patients who have just walked into our ICU with cardiogenic shock and they are unstable hemodynamically, with all their end organ perfusions are unstable. So we need to stabilize this patient, understand the problem with this patient, and then think about whether he is a candidate. Maybe a patient who has been rolled into your ICU is already a brain dead patient because he was brought doing a CPR. So we are looking at a very extreme stages. So when such patients walk into your ICU, you have to understand whether these patients should be first stabilized. And then we talk about heart transplant and Lvad therapy and other therapies which were there. So this is known as a bridge to decision. We quickly put this patient, the quickest available now in quite a few hospitals, major hospitals, big hospitals, we hear about an ECMO. So we put these patients on ECMO. First, let's salvage this patient and then take a decision, then what next we are going to do. There is an option of putting up these patients for urgent, super-urgent listing for heart transplant if these patients are on ECMO or short-term mechanical circulatory supports. So as I said, in our Masina Heart Institute, we are now developing a dedicated ECMO team. So even any patients are in a problem in any part of this, our South Bombay, we can pick up the patient or we can bring and give an ECMO, put them on ECMO and then shift into major hospitals where further treatment can be given. Then secondly, we're talking about the BTC or bridge to candidacy. Again, there are some patients which have come in bad shape. Then this patient also needs to be stabilized. They are not coming in arrested stage or in a stage where they are giving us very less time, but then they are candidates for maybe ventricular assist device or heart transplant. Then in that case, we just stabilize this patient and make them a candidate for transplant or maybe as a destination therapy for Lvad. So either we use again short-term therapy if they are come in a very morbid state, and in a collapsed state, or if they are much in a better state, then we can always use this ventricular assist device to take them up to a transplant level. So why, I will next explain to you in further slides. Then bridge to transplantation, which exactly is the same thing like a bridge to candidacy. A bridge to transplantation means that we are stabilizing the patient or buying time with some ventricular assist device, some mechanical support till we get a heart for this patient. Because it's not that easy that we list this patient for heart transplant, and by the time he gets a heart for transplantation, it will be too late. I have seen getting a heart within 6 hours to nearly a year. Patients have been waiting for a heart for more than a year at times. So in this case, if the patient deteriorates, then what options do we have? And in that case, then we can think about ventricular assist device, LVAD, BiVAD, whatever needed, till we pull this patient up to a transplant availability of a heart for these patients. Bridge to recovery. Many times it happens that, as you have seen, some viral infections, then a lot of other things which have caused acute failure in these patients or cardiomyopathy. So these patients can be temporarily put up on this ventricular assist device, and then wait for this heart to improve. Quite a few times there are incidents where the heart really, after giving support, improves to its normal level, and then we can very safely go and explant LVAD and let them continue on their original heart. And the last therapy, what is we call about DT therapy, is known as a destination therapy. The recent innovation, which are really moving very fast into the development of newer devices like HeartMate 3, because I'm going to talk about HeartMate 3 because we have more robust data about it. Now, this has a more technological advance, and it has come to a level that it can give you similar results like heart transplant. So one of the studies which I'm going to talk about says that at the end of 2 years, the results of LVAD and heart transplant is just the same. So, and very interesting, I had been to Boston as an observer there, and one gentleman walked in and then said he was on LVAD HeartMate 3, and he said he is refusing to undergo heart transplant with a simple reason. He said, I'm comfortable, I am leading a much better life, and I don't want to go in for heart transplant because there are some shortcomings about heart transplant, about immunosuppression to be taken regularly. All those things are excluded when a patient goes on LVAD. So it is a promising therapy which may be looked at more keenly in future, with the better options coming in, and maybe LVAD or artificial hearts will become a destination therapy rather than waiting for heart transplant. Next slide, please. So now coming to which patients are really a candidate for left ventricular assist device. So there are certain guidelines with European guidelines which have come in. Patients with more than 2 months of severe symptoms, in spite of optimal medical therapy and device therapy, whatever you're doing, then these patients qualify for left ventricular assist device. Patients with ejection fraction less than 25% and their VO2 max that we do that is less than 12 ml per kg. Patients who are needing more have undergone more than 3 hospitalization in last 12 months without an obvious precipitating cause. Means they have come to a stage where a little bit of mismatch in therapy or not able to manage rehab themselves, they just fall into on the negative side, requiring hospitalization and then again bringing them back. So such patients are good candidate for LVADs or ventricular mechanical circulatory support. Then dependency on IV inotrope therapy. The patients requiring continuously inotropes to maintain their blood pressures and their heart and the cardiac output, they are the candidates and we don't have a heart available. They are on the list, then these patients then just are good candidates for ventricular assist device. Then we are seeing a progressive end organ dysfunction. There is a worsening of renal function, there is a worsening of hepatic function, then there is a reduced perfusion, inadequate ventricular filling pressures, then systolic blood pressure is just hovering between 80 to 90, and anything you do is just not helping them. Cardiac index is less than 2 ml, so this is going to affect all the organs of our body, then instead of just holding on to this patient with just pushing, we can always give them an option of this assist device. But then there is certain things which we need to know. The candidates whose pulmonary right heart is already failing, like severe right ventricular dysfunction, because for if you're talking about left ventricular assist device, then the right heart has to be very good. It has to be functional so that it can support the left ventricular assist device. Candidates with both the ventricles gone, we can't just put them on left ventricular assist device. We have to think about BioVAD till we really get a heart, or total arterial heart, total heart, which is also now being introduced into our market for replacing or supporting these patients for survival. Next slide, please. So if you see that implantation of mechanical circulatory support in patient with refractive heart failure, they are the candidates in class 2A, whether they are level B or level C. So an LVAD should be considered in patient with end-stage HRF, despite optical medical therapy and device therapy, and who are eligible for heart transplantation, in order to improve symptoms, reduce the risk of hospitalization and risk of premature death. Very clearly they have said this device can be used as a bridge to transplantation. So patients who are eligible for heart transplantation, or here we use it before the patients start deteriorating, so to improve symptoms. We use it to reduce the risk of repeated hospitalization and also losing this patient or premature death. And so it's a bridge to transplant indication. And LVAD also should be considered in patients who have end-stage HRF despite optimal medical therapy and are not eligible for heart transplantation. It's not that patients which are eligible for heart transplantation are only candidate for LVADs. Patients which are not eligible for heart transplantation are also candidates for LVAD. So it has much more bigger role to play, and we can reduce the premature death of patients. Next slide, please. So which are the patient and when the patient should be considered for LVAD? The biggest problem maybe is mostly financial. Next slide, please. What we talk about is when do we give this option to the patient. Right now, our decision making is mostly based on the financials or mostly economics. If I talk about the cost, it is beyond the limits of a common man. Maybe a middle class person can afford so much unless they are insured cover. There is some support from the society for these devices, but then there is always going to be a limitations of how many devices which we can put into this patient. So right now, the biggest indicator into Indian scenario is the finances, because the cost of these devices is very, very high, much higher than even when we can put a patient on a heart transplant. But then these are the patients, anywhere we have an Intermac scoring system for LVAD and heart transplant. So any candidate which are between Intermac 1 to 6 are candidate. The 1 is the very severe conditions and the 6 is where there is an exertion limited. So we can give this LVAD or circulatory support for any patients right from Intermac 6 to Intermac 1. Why? Many times what happens is, like, I mean, you must have seen earlier also, whether it was intra-aortic balloon pump or any other support device, we are always putting these devices at a very, very end stage, and then we are expecting miraculous results from this. If we go in with the devices at a much earlier stage when the patient is in much better condition, clinical condition, then the results expected out of them is also much, much better, much higher. Much superior. If you try to use these devices when the patient is on a deathbed, and then you try to convince, and the patient's relative also agree to it, saying that the next minute he is going to die, so you just take it, then we don't expect very good, and this may give a bad name to these devices. So my request, and if you are looking at this ventricular assist device, then we should start preparing ourselves first as a clinician to push this or to suggest this options to our patient much earlier before they are in a bad clinical position. Next, please. So there is a very nice acronym that is being used, I need help. So this helps us to pick up which patients are good candidates for LVADs. So any patients in the red, IV inotropes are a candidate. Any patient which are in class 3B and class 4 and with an elevated nitriuretic peptides Then patients with end organ dysfunction, his renal function is bad, creatinine going above 1.8, creatine, liver function becoming bad, then these are the candidates we should be considered. Ejection fraction less than 25%, here it's written 35, but then it's less than 25%, then they need help. Patients who are on defibrillator going in for repeated defibrillations, then we should not wait for a stage where they are shocked every morning to evening. Believe me, a patient receiving defibrillator shock once a month also is a shocking event for him. They live under a persistent fear when the next shock is coming. It's a miserable life. And I know a patient who was very close to me receiving a shock literally every day, and I gave him this option. Unfortunately, they couldn't afford it. So, and the patient who are requiring repeated hospitalization, more than one hospitalization for heart failure, and we are struggling in to bring him back. So these are the patients who need help. Remember that. Patient coming with edema, elevated PA pressures, and in spite of high dose of diuretic, nothing is helping. We're giving them IV diuretics also, giving them home therapy of milrinone. So now is the time that these people need more concrete help. Low blood pressures, high heart rate, then progressive intolerance towards the guided medical therapy, guideline directed medical therapy. So all these patients need help, and we should give them an options of ventricular assist device till if they are even if they are candidate for heart transplant or not a candidate for heart transplant. Next slide, please. So there are additional indications for Lvads. One is the CRT non-responders. We have put up a CRT in this patient, and it's not helping them. I hope I'm not crossing the line. And causing very physical limitation on the activity and very poor quality of life. Next, please. So in broad perspective, what are the indications? First thing is as a bridge to transplantations and bridge to recovery or destination therapy. For all the synonyms, acronyms I have given you, then these are what we are looking at in broad perspective. It's Lvad should be used, or ventricular assist device should be used for bridge to transplant, and can be used as bridge to recovery, or now we are talking about destination therapy. Next. Next, please. Let's go back and talk about a little bit of Lvad, which I've been mentioning all this thing. What exactly is device? And I'm going to talk about more. I'm talking more about HeartMate here. You'll see a picture, but though there are different other ventricular assist device available into the market. But there's a nice history, and they have been in the market for a very long time. And there is a steady improvement in the design that they have introduced into the market. So HeartMate VE was introduced in 1998, and it was used as an FDA approval in 1998. Where first implant was done. Then by the time this device had a lot of its own problem. The good part of this device, this was a pulsatile flow, like our blood pressure. We could hear the pulse. I mean, you could feel the pulse. But then it had a lot of other problems, resulting into very high stroke rate. And so then the new device which came into a new design prototype which was introduced was HeartMate 2, and that was in 2008, and it was approved as a destination therapy in 2010. Now these devices are continuous flow. So if a patient walks into your consulting and you don't find the pulse of this patient, don't be alarmed. He's still alive, but maybe and that is what actually happened with me. I was told in Boston, why don't you take the pulse of this patient and report it to me? When I was just looking around for the pulse, he said, please. And the patient was grinning at me. So he said, then he opened up the thing and showed me his battery pack. So that's how I came to know, okay, there is no pulse in this patient because of the continuous flow system, which is in this HeartMate 2. Now, there is a more better prototype, better design, which has been developed. This is known as a magnetic maglev technology. So now there are two magnets fitting, and therefore there is hardly any shear which will cause into the blood, and a good flow is achieved by this HeartMate 3. Now, HeartMate 3 was introduced in 2017, and it's considered as a device for destination therapy, a very good device, and a device which can give us results as good as heart transplant at the end of 2 years. It's still just recent introduction. Only time will tell how good they are to replace heart transplant completely. Next slide, please. So there has been a lot of study. The biggest thing what we know is a momentum trial, which has been done with various devices. And till date, there are more than 27,000 patients who are moving around with HeartMate 2. So that's a fair number. Most of them are in Europe and US. We have a much lesser contributions in this ventricular assist device in our country. But as you see, that the results initially, maybe when the HeartMate VE was there, that was the initial introduction. But in last 10 years, more than 1,600 implants with Lvads covering it up. So if you see in more than 1 year, many patients have been supported for more than 5 years, but some are more than 10 years. 126 patients are surviving more than 10 years on this device. Next slide, please. Next. So these are the assembly that you will see. The HeartMate 3 is a very compact device. It literally fits on the heart. The HeartMate 2, we have to put it, we have to bury it under the abdomen or into the pericardial cavity. But the HeartMate 3, the whole motor system just fits on the apex of the heart. So it becomes like a continuity of the heart itself. And then the inflow and the outflow, there is much better device line. So there is the main motor system. Then there is a system controller, and then there are batteries. Now, a battery pack can give more than 17 hours. So remember that if this patient, any patient you consider for LVAD, he has to have a steady flow of electricity at home. You put up an LVAD and then there are frequent breakdowns of electricity, he can be in trouble, because that's what I had a patient from a remote place who was a son of a very rich farmer. The farmers are also rich. Okay. So then he wanted this LVAD, but then he said he didn't want to part with his son. He wanted to stay with him. So and there was no electricity. He thought of generators and all that of thing. Then ultimately he ended up with a heart transplant, which was much better option for this patient. But we have to look into all this part of it. There are a lot of patients who come from Middle East or other countries which are candidates who wants this ventricular assist device to be fitted. We have to know about the other aspect, support system, right from electricity availability and everything, because this whole device works on battery operated. Next, please. So in short, I will give you again the basic criteria which are patients which qualify for ventricular assist device is severe LV dysfunctions, NYHA class 3 and 4. This is a repetition, but will help us to understand which patients again are candidate for LVAD. Age up to 65 to 70 if they are candidates going to transplant. In our country, it is 65 for transplant upper limit. We have transplanted even in a higher age group, but then beyond 70, they are not candidate for transplant. So, but then they are a candidate for ventricular assist device. They should be compliant with recommended therapy, which is required along with this, because they have to be on blood thinners. They need to take care of the other aspect. So they are not in any substance abuse. They are not alcoholic, chronic alcoholic, or very high use of tobacco. These are the candidates which cannot be given an treatment with LVADs. There is a good insurance coverage. It helps them to take care of the cost of this thing, and they need a very good adequate social support system. They have to be told, even walking into a barricade or through this electronic devices, then they have to be informed that this guy gentleman is on such and such heart support system. Then they have to carry with the system. There has to be not only patient education, even the people around them has to be educated of this device. Next please. So patients, as I said, again, the repetition, recurrent hospitalization, more than 1 to 2 a year, then they are inability to tolerate medical therapy. They are getting into this cardiorenal syndromes. They are non-responders to CRT therapy, and patients who are requiring high inotropes. So this is just to put back into place that what are the indication for LVAD therapy. Next, please. Then we talk about why I'm talking about this inability to walk. When we put the next slide, we'll show you that these are the patients who go on why inability to walk. When we put them on LVAD, they really do so well that they are really moved from their less than 1 block to more than 4 blocks, and that is the quality of life which can be giving them from implanting LVAD therapy. Next, please. As I said, patient selections, we have to know the right heart function of these patients before we decide about LVADs. Next. And also the frailty of these patients. If they are very frail, very weak, very morbid, then I don't think they should be a good candidate for LVAD, because we don't know how well, how long they will be pulling on even with the best possible therapy. Now, evaluating a right heart function is very important before we pick up these patients for LVAD. They have to have their RVSI, that right ventricular systolic volumes, more than 300 milligram, and CVP less than 15 millimeter. Then the tricuspid regurg has to be minimal or moderate. Then the pulmonary vascular resistance has to be less than 4 Woods, or the transpulmonary gradient less than 15 millimeter, and the RV size less than 200 millimeter. The diastolic volume less than 200 ml, and systolic volume less than 177 ml. So these are the candidates who can be considered for left ventricular. So that means their right heart has to be better. So just to summarize, their CVP, just what we understand, CVP less than 15, they are candidates with a good heart and a good right heart. Then PVR of less than 4 Wood, TPG of less than 15. And if you see an echo, their right ventricular volume and diastolic volume should be less than 200, and systolic volume should be less than 177. So these can be referred for ventricular assist device. Next, please. So these are the independent predictors with the right ventricular failure and the HeartMate 2 BTT trial that we had. So independent predictors were preoperative ventilator support, the CVP with the pulmonary wedge pressures ratio more than 0.63, and blood urea more than 39. These were the candidates which didn't do very well with LVADs. And same thing if CVP is more than 15, blood urea more than 46, and a very high infection in setting in these patients, also don't do very well with LVADs. Next, please. Very important, even if a patient comes in, a preoperative optimization, a detailed study is very important before we decide about their candidacy for LVADs. Next, please. So what all, I am just going to quickly take you through the cardiovascular status. What we have just now saw about the right heart is very important. Left heart may be very bad, but then they are a candidate. We need to do a detailed study. We have to look into the arrhythmias, these patients, how bad the arrhythmias are, because till date, arrhythmias, intractable arrhythmias are contraindication for VADs. But then arrhythmias which are coming because of the dilatation can also now then extended candidates for VAD, because once the patients are VAD, once we empty the left ventricle, then the arrhythmias also settle down. Severe valvular dysfunctions, we can't take them for ventricular assist device. We have to look into their renal functions, detailed pulmonary functions, other coagulopathy if they are having, then hepatic functions, malnutrition, diabetes, cerebrovascular disease. If they are already having a stroke, then they are not a good candidate for ventricular assist device. The history of GI bleeds, because of the non-pulsatile flow, this patient go into again having a propensity for high GI bleed. So already if they are having a GI bleed, then they don't do very well. Then they have a repeated GI bleed requiring repeated GI intervention. Surgical consideration, we should see that whether there is infection in these patients, what is their body habitus. Very small patient, then the device may become difficult to fit into his chest. Then and prior surgeries, repeated surgeries he has undergone, and there are other coexisting cardiac conditions requiring surgery, then they may not be a good candidate. So preoperative assessment is very, very important for before we deciding patient for LVAD. Next, please. So our goal before if the patient even is bad, we should try to bring them to this. So these are preoperative goals are what we is blood urea. We are getting down less than 40. We should get the serum creatinine to less than 2.5. we should see that the GFR improves and goes above 50 ml per kg. His INR should be less than 1.2. Hemoglobin should be good, more than 10 grams. Then platelets, good platelet count, more than 1.5 lakh. He has to have a good nutritional condition. His pre-albumin more than 15, albumin more than 3 grams, transferrin level more than 250. And that is what Dr. Tala was talking about in a heart failure, how important transferrin is. Hepatic function has to be seen. His total bilirubin should not be more than 2.5. His enzymes or ALT, AST should be less than 2 times of normal. And he, hemodynamic wise, his CVP less than 15 and pulmonary capillary wedge pressure less than 24. So these are the goals which we have to achieve before we subject the patient for ventricular assist device. Next, please. Some quick results of HeartMate 3. I will put it up. Next, please. So just wanted to show how this LVAD can make a difference. And very soon we are going to compete with heart transplant results with this HeartMate 3. So there is a momentum trial which was done with this HeartMate 3. There is a highest published survival rate for any LVAD with HeartMate 3. There is a immediate, significant, and sustained improvement in functional capacity or quality of life of this patient, and it has a far better, excellent safety profile with the lowest possible published adverse events so far in 2 years' time. Next, please. I think this is a repeat of the slide. Next, please. So what are we looking at? We are looking at now the 79%, what you must have seen, even what our team from Fortis and Reliance had achieved of our heart transplant, or anywhere in the world they have achieved, is an 80% survival. So this 79-80% is a magic figure in transplant and now in LVAD also. So survival at 2 years with this, what have we achieved with HeartMate 3 is 80%, which is also with an heart transplant. Next, please. Next slide, please. So if you look at, these are certain slides with an heart transplant somewhere in 2017, we had achieved 82%. And with HeartMate 3, we are achieving nearly 79% of survival after the abysmal results with optimum medical therapy. Next, please. A couple of slides only now. So we can just 2 more slides, I suppose, before I just close down. That will just give us the good results about with the HeartMate 3. Next slide, please. So this is what I was talking about. See the improvement in the walking of the patients. If you look at, there is a remarkable improvement in the exercise tolerance of these patients after LVAD. So with a severe heart failure, they can't even cross over 136 meters. It has been increased by 2x into 323 meters. The survival is much better. Quality of life has improved 3+ to these patients. Next slide, please. So as I said, the good part about this HeartMate 3 is the stroke rate, which and pump thrombosis. This is always in the mind of every cardiac surgeons or any physician. So these patients, stroke rate has significantly improved with HeartMate 3, and what has been reported pump thrombosis is just less than 1% in these patients. And we see that overall hospitalization has also dramatically reduced in case patients with HeartMate 3. Next, please. So this is the registry that we are putting it up. Next slide, please. Just to close down now. Freedom from stroke, as we see, is more than just the stroke where is 10%. The freedom from stroke in HeartMate 3 is 93%. Next, please. So having said that, just to summarize, LVAD is a very good option now with HeartMate 3, reaching results vis-a-vis with heart transplant. So patients who I can say now in bracket affording patients because the costs are still very high in our Indian market, and can give us results as good as heart transplant. So we can provide this therapy to our patients who deserve it. Thank you very much.
Thank you, sir. Thank you. It was a very, very informative one. And the most important part of this entire today's talk on heart failure that the carry-on message is that we should be aware so that we can offer the patient very early. The early referral is the most important, the key to this. Unless we are aware that what is available, we can't offer it to our patient. So thank you very much, sir. Now we are coming to the actual part, that ECMO, which is very fascinating to me also. So this is the next speaker is Dr. Jumana Haji. She is a consultant cardiac critical care in Department of Heart Lung Transplant and Advanced Cardiothoracic Surgery at Sri Sir H.N. Reliance Foundation Hospital, Mumbai. She is a mechanical circulatory support provider, Ecmos specialist. 17 years post MD from KM Hospital, Mumbai, trained in ECMO in Singapore under the mentorship of Dr. Grim McLaren and Dr. Ramnathan at National University Hospitals. She has managed more than 60 ECMO cases with very gratifying results. She specializes in mobilization on ECMO and awake ECMO for early recovery and rehab. So, as we know now, we are all aware that ECMO is a bridge to transplant. May I call upon Dr. Jumana Haji for her presentation. Dr. Jumana.
Thank you, sir, for that kind introduction. And I think what I do is a bridge to what the cardiologists and the cardiac surgeons do here. So I am the bridge. And Dr. Hamdale has made my talk very easy because he has clearly shown me, clearly clarified all the terminologies that I'll be using. So I will be basically discussing what extracorporeal life support is, what is the principal types and indications, the ECMO components, what are the strategies we can use to cannulate a patient, and how the hemodynamics and the gas exchange holds on ECMO. And then finally, I will talk about which mechanical assistant device to use in an acute setting and what are the outcomes of ECMO. I'm not able to change my screen. Can I have the control?
Sarah?
Ma'am, the control is with you only. You are sharing the screen.
Okay, sorry. 1 second. Okay, fine. So, I don't know why this is slow. Okay, sorry. Okay. So extracorporeal life support has many indications depending on the cannulation and the indication. We have the veno-arterial ECMO, which is used for acute circulatory failure, the veno-venous ECMO, which is used for acute respiratory failure, the hybrid ECMO, which is used for the combined failure, where you have a cannulation strategy which will support the heart as well as the lung. For organ donation, we do ECMO-assisted donation after circulatory death. This is a very interesting topic by itself because it can support it supports the organ and is basically to get good quality organ with least ischemia time and does not aim at saving a life. Then you have eCPR, which is a CPR which is assisted by ECMO. And finally, you have ECOR, which is a miniature ECMO flow and circuit, which is used for just carbon dioxide retention. For today's, I will be concentrating mostly on veno-arterial or cardiac support ECMO. So basically, the principle is that it is a modified cardiopulmonary bypass for management of acute or chronic, acute on chronic cardiac failure. It can be cardiac, respiratory or cardiorespiratory failure in patients who have failed conventional treatment. There are 4 types of indications, as Dr. Hamdale said. So basically, there could be bridge to recovery, where you know there is a reversible single organ or dual organ failure, which if given time will improve. Then there's a bridge to bridge, where you have an acute on chronic cardiac failure, you put the patient on ECMO and then bridge them to something like Dr. Hamdale said, the LVAD. Then there is a bridge to transplantation. While a patient is waiting on ECMO and decompensates after listing, you have a bridge to transplantation. And bridge to therapy. That is, in future, you will have a future total artificial lung, but we are far from that. So in an acute setting where an eCPR is going on, it is usually a bridge to decision or whatever seems reasonable, which could be withdrawal, or organ donation, or recovery. So the ECMO components consist of a centrifugal pump, which works on the which generates flow by creating a negative pressure through the centrifugal action and pushing blood forward towards an oxygenator, which will then which has three functions. One is to do gas exchange, and the other is it maintains the temperature of the blood. So the gas exchange will be oxygenation and carbon dioxide removal. A typical oxygenator from inside looks like this. It is made of polymethyl propylene fibers, which is selectively permeable only to gas. The blood flows, the gas flows through these tubules, and then there is a water heater tubule, and the blood flows between this, achieving gas exchange as well as temperature control. And then the inflow and outflow cannula. So these are the different components which come together to give you an ECMO circuit. The inflow and outflow cannulas, this is usually the arterial, and this is a venous. The venous is always put in peripheral ECMO is always put in one of the femoral veins to get a flow to the ECMO machine, while the arterial, wherever the arterial cannula is put, based on that, the configuration of the ECMO is decided, whether it is, well, we know arterial ECMO when the arterial cannula is in a major artery. It's venous ECMO when the arterial cannula is in a major vein. So for more clarification, the cannulation strategies decides what type of support you are providing and what type of ECMO you're providing. So this is the simplest this is the simplest form of peripheral veno-arterial ECMO. It is something that should be instituted in an emergency situation where, especially if you're doing a CPR or you need the patient to be stable while you are cannulating. It is very easily achieved by putting a femoral vein, cannulating a femoral vein for access and a femoral artery for return. Here, this is the simplest form of a venous ECMO, and the most often used form of venous ECMO with two cannulas, where you take blood from the femoral vein, put it through a oxygenator and push it back to the into the internal jugular artery, internal jugular vein. Now, in a femoral artery, fem veno-arterial ECMO, if you notice, you are pushing blood back into a femoral artery. So the flow of the ECMO is retrograde to the flow of the aorta. So this is not physiological, while in a venous ECMO, the flow of blood is in series, or the physiological, it goes from the lower body to the upper body, from the IVC to the SVC. So then you have the central support configurations, where you have the venous ECMO. Then you need to, this kind of ECMO is usually put in an intraoperative setting, or when the patient is extremely sick and there is an open chest available. So when you go from IVC to RA, you have a central venous ECMO. When you go from RA to aorta, it is a central veno-arterial ECMO. When the IVC to pulmonary artery is your RVAD configuration. And if you put an oxygenator into it, it becomes an ECMO, which can later be converted into an RVAD. Similarly, if you put cannulas into the LV and the return cannula into the ascending aorta, it is an LVAD combination. And if you put an oxygenator into this is a central ECMO, which can later be converted into a VAD. So the next so this is a simplified version of the circuit, where there's a venous cannula coming out from a major vein like the femoral vein. You go to a centrifugal pump, and the pump pushes the blood into an oxygenator, which has a sweep gas and a gas blender or oxygen supply, which will oxygenate the blood and push it forward into the arterial cannula, which if it is in a vein, it becomes a VV ECMO. If it's in artery, it becomes a VA ECMO. You can also put other extracorporeals into the circuit like the CRRT machine or filters, which endotoxin filters. And you always have a heater cooler unit in the circuit. Now, in a peripheral veno-arterial ECMO, because we are pushing the blood up against the gradient of the femoral artery, the limb on which this ECMO is has a high chance of being receiving less blood supply and hence ischemic changes. So we put a distal reperfusion cannula, which is directed downwards and gets blood from the arterial cannula, which goes downwards into the limb. So instituting a distal reperfusion cannula is extremely important. Now, what we get is a kind of differential hypoxia in the body if the lungs of this patient, so half the flow is going through the native lungs and forward flow into the aorta, while half the flow is going through the oxygenator and upwards into the aorta. And there is a demarcation mark where both the flows meet. This is the point at which mixing happens. So you more often than not, the coronaries and the brain are supplied by the blood which is going through the native lung. If the native lung is not functioning well because of pulmonary edema or ARDS, you will find that the right side of the body is deoxygenated while the left side of the body or the lower body is better oxygenated. That's why in an ECMO patient, in a veno-arterial ECMO patient, we always look for oxygenation on the right side of the body to know what is your coronary and your cerebral blood oxygenation. And this is called as differential hypoxia or Harlequin syndrome. So in a veno-arterial ECMO, it offers hemodynamic support in addition to respiratory gas. So it is complete support, but the central venous circulation serves as the source of the ECMO pump preload, and the return cannula is placed into an artery. And the cardiopulmonary bypass system works in parallel to the native cardio. So there are two hearts, so to say, a central and a peripheral one. Now, this is where you are taking returning to the IJV, so into the RA, and this is, like I said, physiological. The native lung has a much higher capacity for oxygenating compared to the membrane lung. So we have to understand this when we have expectations from the membrane lung. So the surface area and the oxygen and carbon dioxide delivery and removal that the native lung is capable of is 10 times that of, or more than 10 times of that of the membrane lung. So these are the settings which help us to create, to support the ECMO, that help us to support the heart and the lung. We have the ECMO flow, which should be at least 60% of the patient's cardiac output, to ensure that more than 50% of the blood is going through the system to give us enough organ support. And then you have the FiO2 as well as the sweep gas, which will determine how much oxygen you are supplying via your ECMO. Now, in this if the peripheral cannulation is applied, any residual cardiac passes through the lungs, and if the lungs are diseased or mechanical ventilation is insufficient, as I explained, the blood of the residual cardiac output will remain hypoxic as it enters the systemic circulation. Anatomically, there is a potential for hypoxic blood to be delivered to the head and right arm, and that's why this I've already said. Now, what are the hemodynamic changes on VA ECMO? With increasing the flows on a veno-arterial ECMO, as you go from baseline to flows of 1 liter, 2 liter, 3 liter, your pressure volume curve moves more and more rightwards. And what happens effectively is that your LV volume, LV pressures, the aortic pressures will go on increasing. Your MAP will increase, but your pulse pressure will go on decreasing. And the output from your LV will go on decreasing because there is more and more afterload created. So as you go higher and higher on the flows, you will find that the flow becomes more and more non-pulsatile. Your mean arterial pressure becomes the indication of how much is your ECMO support and your hemodynamic support. However, you may reach a stage where your aortic valve doesn't open at all and there is no ejection from the LV. And this is a point which you want to avoid, because then there is LV distension, LA distension, and then pulmonary edema and apoplexia. Your right heart actually benefits from ECMO, peripheral venous ECMO, peripheral ECMO, veno-arterial ECMO, because you are taking blood from the right heart and decreasing the right atrial pressure. And so the RV preload is reduced, the retrograde blood flow is increased, that is LV, the retrograde blood flow increases the afterload and LV distension. The aortic valve barely opens, causing stasis of blood within the LV chamber. The LV stasis can turn into an LV clot, or increased LV afterload can lead to pulmonary edema. So we have to think of LV unloading strategies in this case. Firstly, you can reduce the ECMO flows, and if you don't have harlequins or your lungs are working well, you need to go down on the ECMO flows to a point where you are ejecting effectively. You can use inotropes only in this condition. So it is important to rest the heart when you are on ECMO. But if in case you have a ejecting flow, you need to go to, you need to resort to inotropes or vasodilators to decrease the afterload. IABP is an important, IABP may be helpful in decreasing the LV afterload as well as LV emptying. The other surgical resorts may be a balloon atrial septostomy to divert the flow from the LV, or the cannula from the LA to aorta connected to venous port of ECMO circuit. So you do a vent, and or you resort to a central ECMO if this is a problem. So what is the case of IABP plus ECMO to decrease LVEDP and pulmonary edema on ECMO? Well, the logic is that VA ECMO system re-injects blood countercurrent to the descending aorta. This increases the left ventricular afterload, as I said. So the latter is even more frequent in patients who have little or no residual LV ejection on ECMO. In this context, hydrostatic pulmonary edema can form, and IABP, which inflates during diastole and actively deflates during systole, increases coronary blood flow and reduces the LV afterload. So some ECMO centers systematically combine IABP and ECMO to prevent pulmonary edema. And it has been seen that the use of VA ECMO alone versus IABP ECMO plus ECMO, the latter shows a better 28-day survival and in-hospital survival and weaning from ECMO. So which mechanical assistance device should one resort to for heart failure? The case of the IABP, we know how the IABP functions, but the IABP SHOCK 2 trial did not show a very improved 30-day mortality or long-term benefit of IABP in acute coronary syndromes. Why is ECMO preferable? Because it is like IABP, it has a peripheral vascular access, and it is easy and rapid implantation of peripheral ECMO is possible. So there's no need for a sternotomy, cardiotomy, or anesthesia also in an emergency situation. It provides a high and stable outflow. Basically, it provides complete and superior circulatory support. It also helps your heart as well as lungs simultaneously. So in case you already have lung failure or desaturation, you can revert that or help that with ECMO. And it is a proper bridge. So every time you counsel or put a patient on ECMO, you need to know what the bridge is to. Bridge to recovery, bridge to a bridge to transplantation, and bridge to withdrawal. You have to understand that this has to be counseled to the patient relatives at the outset, that it can be a bridge to nowhere or withdrawal, but these are the other options which can be depending on the indication, which is why we are putting. And it is definitely not as expensive as most of the other options. So yes, IABP is 5 times cheaper, but the rest of the devices are five times more expensive. So it's something that people can afford if it is used, and should be offered if it is used in the correct window. And definitely VA ECMO has shown a 33% higher 30-day survival compared to IABP. So, okay, you can use IABP as a first line of treatment, but always keep the ECMO standby and put it as if it is not achieving your goals. And also choose your candidates well if you do not want to incur two costs. Otherwise, an IABP sequentially followed by ECMO may be a good option in most patients who present with in Intermax 1 condition. So medical cardiogenic, where is it a bridge to recovery or therapeutic? Mostly in myocarditis, drug overdose, Takotsubo, where you know that this is a reversible condition and you will be able to get the patient off ECMO as a bridge to recovery. In acute myocardial infarction, if you have a culprit vessel that you can open up, but the patient is too unstable, ECMO is extremely indicated and should be considered maybe even before IABP if refractory to conventional treatments. If your rate of increase in inotropes is extremely high, quick, then you may want to not waste any more time putting in an IABP and put ECMO directly, or keep ECMO standby. And you must do this in the window before end-stage multiple organ failure sets in and the patient's urine output and liver functions take a hit. Post-cardiotomy, yes, this was one of the most used therapies, like when you cannot wean off CPP. This type of ECMO has been used for many years in India. The rest of the indications are now new. And cardiac arrest, we may be a little far from actually using ECMO in eCPR just because of the response time. And that's why it's important that we include our ER colleagues into institution of ECMO, because this is the point. If this is done immediately, then yes, cardiac arrest can, ECMO for eCPR can be a bridge to recovery. When do you put a patient on ECMO? So you have to see the time course of an etiology of the disease. How has the patient presented and why? Whenever there is a reversible condition, we should immediately, even before your inotropes start increasing at a rapid rate, you must think, talk, and counsel ECMO, because there is a very big time lag between actually thinking and instituting ECMO. What is the clinical status, in particular the neurological status? Was the patient awake before this episode, or was he already, in a mentally depressed state? Other clinical signs associate, so we should not put a device, obviously, if it is futile. Other clinical conditions that, like Talha mentioned, when your patient starts getting abdominal pain, alteration of consciousness, rhythm disturbances, hepatic and renal failure. There's a lot of times when people will institute CRRT when the patient becomes anuric because of cardiac failure. But your CRRT is only going to make this worse, because you are now going to draw some blood in from a failing heart, and decrease the preload as well. And it is not going to, support any of your abdominal organs. So your liver and renal hit will keep on worsening. So actually, this is when the renal hit becomes apparent with your creatinine going up and your urine output dropping, this is the best time to institute ECMO, so that your abdominal organs as well as your coronaries are well perfused with oxygenated blood, and further deterioration stops. And once these improve, you can bridge them to another bridge like an LVAD, or put them on a super urgent transplant list, depending on what their original, if it is acute or chronic, or if it can be a bridge to recovery also. So basically, this is the window that we are looking at. And you look at a Doppler echocardiography. So your echo is actually your one definitive this thing. Every time you think ECMO, there has to be an echo 4 hours prior to actually deciding what cannulation strategy you will use. And you have to look at the aortic valve VTI. So the results of ECMO in context of acute refractory cardiac failure. In this paper of outcomes and long-term quality of life of patients supported by ECMO, they've studied 81 patients the best results were from myocarditis and post-cardiotherapy, and 10 patients who were transplant candidate, out of which 30% made it home. So basically the ICU survival was 42% and the long-term survivors were 36%. The factors which were independent predictors of ICU death were the urine output and prothrombin time. Myocarditis had the best outcomes, and worse outcomes were seen with ECMO under CPR. So who should benefit from CPR? When it is a witness cardiac arrest, there is no flow for less than 5 minutes. There is good bystander CPR, age less than 50 to 60 or physiological or frailty, as Sir said, and cardiac arrest of presumed cardiac origin, where there is an initial shockable rhythm. So arrhythmias again is a very good indication for putting on ECMO, because more often than not they stabilize immediately, especially if they are going into continuous VTVF arrest. And ensure that there is efficient CPR while you're instituting and your ETCO2 is more than 10 millimeter of mercury. So basically collapse to ECMO time is most important, and we don't have it in India yet, but this is where we are headed and this is what we should aim for, is at least for in-hospital collapses, if not, because we don't have good retrieval teams, but at least for in-hospital collapses, there is no excuse. So which mechanical pump will you use? Of course, the Intermax levels, the most critical are the ones which come with critical cardiogenic shock or Intermax 1. And ECMO offers a complete, complete heart-lung support for these patients. And it is easy and quick to institute peripherally. The rest of them, the tandem heart, the impeller, can be peripherally put. Definitely you can't go to VADs in this situation because you don't know where you're headed, and you have to bridge the patient before you think of a VAD, from the technical aspects as well as from the cost aspects. So just to put it in perspective, an IBP would be a peripherally put balloon pump, which would decrease the afterload and improve the coronary circulation. An impeller just helps to decompress the LV and divert blood to the aorta when there is dilated cardiomyopathy. But the ECMO with the oxygenator in circuit does both, and the IBP as well as the impeller are good adjuncts to ECMO, because ECMO does tend to worsen the ventricular dilatation as well as ejection from the heart by offering a very high afterload. But it still, if it is an ejecting heart, there is no harm done. So the combination of one of these with ECMO is perfect. And then finally, you have the tandem heart, which is ECMO without oxygenator. So at any point, your ECMO can be converted into a tandem heart, which can be kept for a longer time, because all the problems that your oxygenator offers, like need for anticoagulation and platelet drops, is not there with a tandem heart. So once your patient has come out of the acute phase, you can put them, remove the oxygenator from the circuit, continue them on the pump till you get can figure out the next, or get them to overcome any infections or to get an organ. ECMO for fulminant myocarditis. This is a patient of aluminum phosphide, which we had put on peripheral VV ECMO. Patient refractory cardiogen, and this is a study which the outcomes from 2003 to 2009 of 41 fulminant refractory cardiogenic shock patients due to fulminant myocarditis. They were tried with mechanical assistance thyrovac. They found that 41 myocarditis patients, 33 underwent peripheral VA ECMO, 10 died in ICU, and 4 went to heart transplants. But the long-term survival was almost 68%. With 4 transplanted, that is 10% patients undergoing transplant. The independent predictors of ICU that were at admission was SAPS2 more than 56 or a troponin C more than 12 grams per liter. Bridge to a bridge, improving outcomes in this paper, which talks about improving outcomes in Intermax category 1 patients with pre-LVAD awake veno-arterial ECMO, that is extracorporeal ECMO, showed that the awake ECMO allows for clinical assessment and temporarily supporting the biventricular functions while stabilizing the end organ functions. The aim of the study was to assess outcomes of the patients with a VA ECMO support before durable left ventricular assist device implantation. 83% received LVAD, 19 received an awake ECMO before the LVAD. So the survival of the awake ECMO group was 84%, while that without awake ECMO was 66%. And survival of the awake ECMO was comparable with that of non-awake ECMO Intermax 2 cohort at 1 year. So it demonstrated a significant reduction in a risk of death in VA ECMO, awake VA ECMO group compared with Intermax 1 non-awake ECMO group. While on awake ECMO, when the patients put on awake ECMO, it allows you to bridge to next therapy, improves your outcomes for Intermax 1 patients, and downgrades the disease on the Intermax severity scale. And you can also, because it's an awake ECMO, you don't lose any muscle power or problems of chronic ICU. You can exercise them the same as you would do on a peripheral VAD or a central or peripheral VAD. So there is a definite, survival advantage when ECMO is used as a bridge to bridge. ECMO in heart transplant patients, what we found was patients in the ECMO group were younger compared to those in the continuous flow LVAD group. They were more likely to have severely disabled functional status, but they had a shorter wait list because in most countries now, patient on ECMO awaiting heart transplant becomes a priority and gets listed as super urgent. And they were more frequently mechanically ventilated than were patients in the continuous flow left ventricular assist device group. Again, here the window is very important because if we catch these patients before they need mechanical ventilation, their outcomes would be much better. However, we must understand that an ECMO can be safely run only for 9 to 10 days. So if within that time we are not likely to get an organ, if in a country like us, we have to think of other bridge therapies when we are putting a patient on ECMO. So the predictive risk factors for primary graft failure requiring temporary ECMO post-operatively, 91%, in this paper, we found that 23% patient had primary graft failure, and the predictive factors were age more than 60 years and preoperative mechanical circulatory support, because these patients are much sicker. So post-operatively, they came out on ECMO. The donor factors were very high norepinephrine requirement prior to transplantation, trauma as a cause of death, EF less than 55%, and a longer ischemia time. Weaning and discharge rates after ECMO support for PGF were 60% and 46% respectively. So surviving patients who were treated with ECMO for primary graft failure was similar, and and their 1-year survival rates were similar to that of non-PGF patients post-heart transplant. And hospital survival was 46%. This is data which collaborates that ECMO support, if a patient of heart transplant needs to be does not need to be supported with ECMO, their outcomes are definitely very good. If they need to be supported pre-operatively, they at least make it to transplant and a 100-day survival, but their long-term survival is still questionable. But those who require post-heart transplant, their survival is 68%. So in conclusion, ECMO is a modified cardiopulmonary bypass for management of acute onset cardiac or respiratory or combined failure in patients who fail conventional treatment. It is a bridge therapy, so it should be initiated keeping the treatment options in sight. Simultaneous cardiac and pulmonary assistance is offered by ECMO. IBPs may have a beneficial effect on some hemodynamic parameters, but did not result in survival benefits. Combined IBP with ECMO has more benefits. Timing of initiation is of paramount importance. Awake VA ECMO is best as bridge to LVAD as well as transplant. Mortality rate is higher in patients requiring ECMO support pre or post heart transplant. Surviving patients treated with ECMO for PGF have similar conditional 1-year survival rates as non-primary graft failure patients. We must remember that ECMO is a window. ECMO is a window, and I'll leave you with a painting by my dad, which is of a bridge. ECMO is bridge therapy, and it is a bridge to transplant, or bridge to recovery, or a bridge to a bridge. Thank you.
Thank you, Joanna. It is very informative. In fact, we don't have a time for question answer, but only one question to you, whether you have mentioned it during your talk. Is it for the transportation of a patient from one place to the bigger center where they can be offered?
Absolutely. So basically, it should be very important, like I said, to keep the end goal in this thing. I've put this slide because this is, these are COVID times, and this is the ELSO data for ECMO for COVID. Basically, this is where, what we are doing now is, initially we did not offer ECMO for COVID, for example. And now there are patients who are stuck on ventilator for 30 days and there is no improvement in lung visible in sight. So we are counseling these patients as bridge to transplant, offering them ECMO and then transporting them safely to transplant centers. So definitely, if a patient is unstable in another hospital, ECMO has to be instituted before transport. But should be clear what we are transporting for. If the family understands and has been counseled adequately for transplant and they're willing for that, that is the best case scenario, because then they are willing for everything. If we are transporting to a center only for recovery, then you are looking at recovery versus bridge to nowhere, which becomes a very difficult situation.
So going with the same word, bridge, these CMEs are also bridge from the general practitioner and the family physician's point of view to the higher centers and a higher understanding about what is available for our patient to the best. I thank you all. I thank all the speakers today. Very, very informative. And the people who have joined lately, or if they want to tell their friends, this is available on our the Bombay Seaward Medical Association YouTube. And I thank at the end all the associations for joining, the members joining. You will get your MMC points also here in our first Sundays of every month. And thank you for have a very nice Sunday afternoon and all the best. Thank you very much. Thank you. And
thank you very
day.
much.
Thank you.